Call this meeting of the Craven County Board of Commissioners regular session for Monday, April the 15th, 2024 to order. Madam Clerk, if you will, please call the roll.
Commissioner Howard?
Here.
Commissioner Hunt? Here. Commissioner Mark?
Here.
Commissioner Mitchell?
Here.
Commissioner Smith? Here. Vice Chairman Booker?
Here.
Chairman Jones?
Here. Ladies and gentlemen, if you will, please let's stand together as our County Attorney, Mr. Eric Grady, will lead us in prayer. And after the prayer, I ask you to remain standing for the Pledge of Allegiance to the American flag.
Almighty God, Creator, Preserver, and Governor of all things, we humbly bow before you on behalf of those gathered here, individuals who find pleasure in serving the people of this great county. With thankful hearts for your goodness to each of them, we earnestly pray that you will take their minds and give them a new measure of wisdom, take their hearts and fill them with your love for others, and take their wills and make them more obedient to your will. May your servants here proceed step by step, hour by hour, to meet the challenges you have given them, so that in the end, the purpose that you have set out for this Board of County Commissioners may be accomplished for the enrichment of people across this land and to your honor and glory. This we pray in your holy name. Amen.
Amen.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Good morning to everyone. We appreciate you being here this morning. To those that may be viewing online, we welcome you. I would ask that all of us in attendance would check our cell phones. Let's make sure they are on silence. We would appreciate it. We have several, everybody's special guests, but we definitely have several here with us today that we will be recognizing at a later time. But again, we thank you all for being here. Commissioners, you have before you your agenda packets. One item that I just want to draw attention to, we will talk more about it in a few minutes, but they will be under consent agenda under tax releases and refunds. I will be asking that we pull, when we get down to item 3 under consent agenda, I will be asking that we pull item B, and we will explain that more in detail at that time. Are there any other items that you desire to pull or add from the agenda today?
I approve. I would make a suggestion to approve the agenda with the discounting.
Okay. All right. We have a motion and a second to approve the agenda with the inclusion that when we get to the consent agenda, we will be pulling B. Is there any more discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? Motion passed. The first item we have before us this morning is the City of Newbern Parks and Recreation presentation on the Newbern Pier project. We're honored to have with us Mr. Foster Hughes, the city manager, and also we have Alderman Astor with us. Welcome, sir. We certainly appreciate you loaning us your son. He's a blessing to Craven County, and so, but welcome to you, sir. Welcome.
Good morning. Thank you for having me today, and I'm here to talk about a proposed pier project that we are looking at for the Broad Street terminus. So for the better part of the year, the city has been working on a concept for a fishing pier in the general area, and over the last several months this project has really started taking shape. We've come up with a proposed plan, which you may have in front of you. Okay, it's right up here on the screen. And so, and I'm just going to talk through it a little bit. You see the Broad Street terminus. To the left of that is slightly a fishing pier. It's approximately 10 feet wide, 225 feet long, and it's T-shaped, and each part of the T is approximately 50 feet long. And so this is what we're looking at. And of course, in order to do this, we're going to need some assistance from Craven County because a good portion of this pier would extend upon your riparian zone. In order to work through this design, which is the preferred design, we would need to work out some type of long-term lease agreement for riparian rights. And this is what we're asking for your blessing to work with, have our attorneys work with your attorney to work through this. We have the funding in place to build the pier, and we're looking at doing this in 2 phases. First phase would be to build the pier. The second phase would be to do the parking as you see on the proposed concept plan. And I'm happy to answer any questions you may have.
All right, Commissioners, Vice Chair Booker.
Currently, most any time that I walk around that area, there are people parking where it says no parking, obviously, on the county property, or maybe it's I can't tell where the county and the city come together, but on your, yeah, either on your or our property.
Correct.
I counted 11 cars there the other morning, and these people are fishing, and it makes it difficult to walk on that walkway because you're walking across fishing lines, and then they have a nasty habit, some of them, of leaving litter when they get done with their fishing. Obviously, this pier would be an advantage for them. Would we then restrict people from parking and fishing along the walkway?
We would definitely restrict them from fishing, literally from Council Bluff all the way over, actually, past Sky Sail. No fishing along any part of the river walk itself. That would be the only area on the noose that you could do that. We already have several fishing piers over on the other side of the city, and so that's not an issue. The big thing with people parking on county property is, if you want to put some signs up and you want to let us know that, hey, we want this enforced, the city will definitely enforce the no parking issue with that.
Well, once the parking is done, there's no reason.
That's correct.
For them to park over there. But, I mean, there are people over there with campers.
Yes.
And, it's become just a public, do whatever you want to do area.
There's a camper over there right now. Saw that this morning.
Commissioner Mitchell.
Thank you, Mr. Hughes. I appreciate you presenting this. I've been hearing about it, but I haven't actually seen what it looked like. Several questions. How many parking places would y'all add?
There are going to be about 25 parking spaces that we're going to have in this.
Okay, are these paid parking or
No.
first come, first served?
First come, first served parking.
Okay, in terms of building the pier and then building the parking for it, what's the time delay in terms of the two projects? Because what I can see happening, if you build the pier and the parking doesn't come right behind it, we're going to go back to everybody parking just exactly as Commissioner Booker is.
Right. So with the CAMA permit approval process, we anticipate being able to actually start building this pier sometime late summer, early fall, with it being in place. The goal would be before this, but by December. And then parking would take place right after that, if not sooner.
Okay, so you can't do them simultaneously, you have to do sequentially.
That's correct.
With it, and, people fish, they catch fish, then they clean fish. The innards of the fish. What happens, what are the sanitary arrangements
So
going to be for that
Right.
issue?
So with this, we will have rules and regulations in place at this pier. We will not have a fish cleaning station on this pier, so they're going to have to put those things in coolers and take them elsewhere to do that. And of course, that would be incorporated in our ordinance with fishing as well.
That's all I have, thank you, sir.
Commissioner Howard, you got anything, sir?
I can't, she answered them.
Okay, this way.
You go. What is the possibility of the parking coming first?
Probably not that great of an opportunity because this will be a laydown yard as well for some of the work that's being done. We already have the funding in place through dealing with a variety of vendors for the pier, so I don't think that would come first.
And you have CAMA approval already?
We're getting ready to go through the process. Really, working an agreement out with the county is the next step for
Okay,
us. And
got
once we get that, then we'll know which way we need to go.
The barge that's out there now, is that got anything to do with this project?
No.
Okay. And I don't know what exactly belongs to the city or the county. So how much what area are you leasing?
So you see where the pier, the terminal was, well, first of all, we have an easement. The river walk is an easement. We also have some electric utilities and things like that come in on the grassy area. But basically, if you look at from sidewalk to sidewalk on Broad Street, it goes straight out. That is city right of way.
Okay.
Essentially where the parking is.
That's correct, where the parking is.
Foster, point of clarity, you're not actually asking to lease any physical land, you're asking to lease the riparian rights from the high water mark to the county's end of those, basically extending out.
That is
to
correct.
waters.
That is correct, yes.
So water rights.
Water rights, that's right.
Any more questions that way? You've already stated this, but just so it's on record, no cost to Craven County. I mean, you're going to foot all the bill on the city side with the funding that you've received and so forth.
That's correct.
Okay. All right. Any other questions, commissioners? All right, staff, do y'all have anything you want to add?
No, I think Foster covered everything. We've talked extensively about this, and think it's a good advantage for all folks in the county to have this opportunity to be able to fish. Clearly, I think one of the points that was very meaningful to me was the ability to put all the fishing in one area and start to free up some of that river walk, to Commissioner Booker's point, be able to corral it, so to speak. And then, of course, some of the parking challenges, I agree with whoever said. I mean, I wish that was in tandem, but we'll work through that.
Do you
Okay,
need
yes.
a motion to authorize? Yeah, okay.
I'm in favor of this. It's in my district. I think it'll be an improvement from where we are today, and it'll take those vehicles and people off of our property and the city's property over at the top of the picture there. Where the bend is, that's where the people tend to park and fish. So I make a motion that we approve the request by the city.
Second.
We have a motion and a second to request a proposal from the city. Will we be receiving anything else back to have to come back and look at it again, Ari?
Yes, sir, I would think so. As I understand the motion, it's also an implicit directive to me and the staff to work with the city to get the lease squared away and whatever else we might need to do.
Correct.
Legally or practically, and we will bring that back to the board certainly before it's executed.
Okay. All right, you had the motion and a second. Any further discussion on the motion? All right, all those in favor signify by saying aye.
Aye.
Opposed? Motion passed.
Thank you.
Thank you. Thank you both. All right, item 2 is the Craven Community Child Protection Team Fatality Prevention Annual Report for 2023, Ms. Jenny Cook. And I think she has some folks with her also, but welcome this morning.
Thank you. I have Antoinette Bosky with me. We both chair the blended team of the Community Child Protection Team and the Community Fatality Prevention Team, and we're here to present the 2023 Annual Report. We have a presentation behind us. In 2023, Craven County Department of Social Services received 1,343 reports of abuse, neglect, and/or dependency. And of those reports, 893, about 66%, met the criteria to be screened in to be further assessed. As you can see, looking at for the last 5 years, 2019 to 2023, the numbers, you can see in 2019, we had 1,124 reports, and now we're at 1,343 screened in, 893, which is about a 19% increase in reports received in the past 5 years. Of those reports, there were 74 reports of substance-affected infants. And again, as you can see, in the last 5 years, it's about a 25% increase of substance-affected infants coming in with reports. Marijuana use was the main substance use. Second and third was fentanyl and cocaine. In all of those reports, there was a referral made over to the health department for further assessment on their end.
And the purpose of the CCPT-CFPT team, we develop a community-wide approach to child abuse and neglect. It helps us understand the causes of childhood deaths. We're able to identify gaps and deficiencies in service delivery, as well as make and implement recommendations that will impact the laws, rules, and policies in a way that we protect our children in this area, and all across the country, actually. Yes, sir.
When maybe it's one with with drugs in their system, what happens at that point? I think I know, but is that what you're saying here?
A substance-affected infant?
74 babies, but weren't positive for drugs, yeah?
Are you asking what happens with those 74 children?
Yeah.
DSS would have to screen that, and if it comes in that services are needed, they'll work with the family. If progress is not made to be able to alleviate the issue that's causing the child to need to be protected, then they end up in the court process.
Do they detox the babies?
Some babies do go through the detox system, yes.
Some are able to withdraw and don't need that. It just depends on what's in their system, and how resilient they are.
Yes.
On this team, the members of that team include representation from the Department of Social Services, representation from Guardian ad litem, from law enforcement, the district attorney's office, the local community action agency, the school system, the mental health professionals, healthcare professionals, emergency response professionals, the court system, the medical examiner, child care facilities and Head Start, as well as the bereaved parent. So the representation isn't just from agencies. We actually have community members who are able to be a part of this team, which gives us a more well-rounded perspective. This year, for 2023, we actually had 8 cases. 2 of the 8 dealt with children's mental health. 5 of 8 were parents' mental health. 3 of 8 were substance use. 2 of 8 were the children's physical health. 2 out of 8 had parenting concerns, and 2 out of 8 dealt with housing needs. For the gaps that we identified, a large majority of our gaps, last year, one of our gaps had to deal with placement of children. This year, a majority of them deal with the placement of our children. We have limited placements due to children's behavior and the level of care that's needed. We have a lack of timely placement of children who are moving from one level placement to another. So if they're moving from a regular foster home to therapeutic home, or moving from a group home to a psychiatric facility. We have a lack of placements when it comes to willingness to accept children with developmental delays. That requires a higher level of care. There's a gap when it comes to mental health services for our children in the school system, and there's limited access to mental health services if families don't have medical insurance or Medicaid of some kind.
The Craven County Community Child Protection Team, we have our meetings quarterly. We meet the 4th Tuesday of the months in January, April, July, and October. When we review these cases, these are cases where abuse and neglect is not found. We review any deceased county residents under the age of 18. We discuss the outcomes of services and circumstances surrounding the child's death to search for ways to prevent the future fatalities. In 2022, there were 6 cases discussed. All of those had perinatal conditions. There was no system problems identified. The parents all received prenatal care. Unfortunately, the babies were born premature, and it was nothing that the parents had done. They were recommended for grief support counseling, and then the proposed action was the health department would continue to provide education about prenatal care along with the hospital. We would use our QR code that was on a previous screen to provide resources here in Craven County. That QR code has been provided throughout the county, and as of this year, since it's been in place, there's been 432 scans providing resources to families. Recommendations from the fatality was partner with DJJ and discussing court involvement with children who have aggressive behaviors and the needs for resources to address youth with serious delinquent behaviors where abuse, neglect, and/or dependency is not present. Nutritional counseling is to help with understanding the importance of healthy food choices. Referrals to parenting classes to educate parents on how substance abuse impacts their ability to parent their children safely. Continue to partner with Trillium to identify and develop and locate therapeutic placements to meet the mental health needs of children in foster care, and provide families with community resources that can assist with housing, veteran services, domestic violence, transportation, and dental care. The areas of focus for 2024: submit appropriate referrals to community partners to help prevent future maltreatment. This includes prenatal services, parenting programs, providing families with community partners, and the QR sheets to help educate, provide families with resources in Craven County. And I will say that Trillium has partnered very well with us and looking for resources. They are available. They make themselves available throughout I mean, we reach out to them through emails, through text messages and stuff, and they partner very well with us in finding placements, even if they're to B3 placements.
And what we realized is, no matter whether it's DSS, Guardian Ad Litem, Trillium, what agency it is, DJJ, it is the laws and policies and rules that govern how we're able to do this work. It governs how the money is funded down for us to be able to do this work. And so we are grateful for your partnership. Yes. We thank you for it, because we know it is with all of our voices and the role that we play that we are able to protect our children.
Question.
Yes, ma'am.
I'm interested to know how you work with the school, specifically the school social workers, and working with these children that have these needs. Perhaps the nurses and social workers.
We partner very well with the school. We communicate with them regarding any truancy issues, how their children, if they have any concerns with the parents and things like that. So we're in constant communication with the school. We are required, DSS is required to have collateral contacts throughout the case. So we're constantly contacting the schools, mental health providers, neighbors, other family members throughout, trying to get a good idea of what's going on within the family unit and what we need to do regarding referrals for the families.
That's also the same for Guardian Ad Litem. And so we are able, with some of our children, a lot of our children, to advocate and work with the school to provide supports in the school system. However, that's with children who are in foster care, right? If we're talking about preventing and protecting our children, preventing child abuse, then we see where that gap is needed before they even reach us. That additional touch or those additional services could prevent a child from coming into care or having to have a family from having to have contact with us.
Okay, other questions, comments? Vice Chair
Well,
Booker.
first of all, thank you both and your whole organization and whoever else you work with for doing what you do, because when we think of adults that have mental health problems, abuse problems, they have some ability to make those decisions to solve that problem. The kids don't.
Right.
And so it's heartbreaking to think we have children born already addicted. And I know it's nothing new, but it's growing, and it's a scary thing.
Yes.
So thank you for that. Under recommendations, you have a number of things. I guess my question is very simple. Is there anything there you need from the county to solve, help you solve any problems you have, or any anything that isn't going the way you would like it to? Anything you need from us? When I look at that list, I don't know.
Well, we continue, we appreciate your support. The funding that y'all help with the Dix Center and the Healing Place in New Hanover helps a lot, because we do those referrals to those placements for these families to help for them to have an understanding of the impact of their substance use on their children. Even after children are born, them to be able to parent safely, their substance use impacts that. If it comes to maybe their homelessness, or if they're out with their employment and things like that, it all has an impact on their children, so helping them see that. So we appreciate your funding. If you could continue with that, we appreciate it. And then any other resources that you may have that might be being brought to Craven County. We always need mental health providers and things like that.
Thank you.
Okay. Other questions, comments? For all the years that I've served on this board, we have many troubling reports that come before us, and definitely today we're going to talk about our opioid epidemic in this county. It's a continued conversation that we have every day in this county that we're in operation. But one of the most troubling reports that's ever come before us is definitely this report. Right. And Jack and I were at a meeting a few weeks ago, and I made reference to this. And the bad thing is it keeps increasing. And Vice Chair Booker put it better than I could say the words, but these are vulnerable, innocent children who, they didn't ask for this. And, it's a bad sickness from those that are engaging in this. And I just hate to see those numbers continue to increase. and it's something that we all have got to work on as we continue to go forward. So, thank you for your report. Thank you for what you do again. We can't thank you enough.
We appreciate you.
Have a good day.
Thank you.
All right, Commissioners, we're to item 3 on the consent agenda. County Attorney, I'm just going to ask you just make sure that we, make sure that we're clear on this and I don't do anything that I'm not supposed to do. Under B, under refunds, today my name is listed under there to receive a refund. Vice Chair Booker, definitely we will let him handle B. Do I have the authority now to ask that we pull B and consider the other items and then turn it over to him, or should I let him handle all of the consent agenda?
I think you're okay. Mr. Chairman, presiding over the agenda amendment, and then we'll have a motion to excuse you when the board considers that particular matter.
All right, we're at item 3, consent agenda. Before you are the minutes of the April 1st, 2024 regular session, tax releases and refunds, environmental health, intern paid with grant funding, budget amendment, a proclamation for National Public Safety Telecommunications Weeks, a proclamation for the Resilient and Thriving Community Weeks for 2024, and a proclamation for the Line Worker Appreciation Day 2024. Commissioners, I would ask that item B be pulled from the consent agenda. Are there other items you desire to pull this morning? All right, here none. Do we have a motion to pull
Second.
item B? And okay, we have a motion. Do I have a second?
Second.
I have a motion and a second to pull item B. Any discussion on the motion? All those in favor signify by saying aye.
Aye.
Opposed? Roll
call.
Well, we're not proving the consent agenda. All we're doing is just pulling item B.
I thought you were approving
Is that
it
all right?
as amended.
Okay.
I'm sorry.
So we have a motion and a second to pull item B. All right, now we will take up A, C, D, E, and F. Are there any items you desire to pull from that? Here none. Do we have a motion
So
to approve
moved.
those? We have a motion and a second. Any discussion? Here none, Madam Clerk, if you will, please call the roll on those.
Commissioner Howard?
Yes.
Commissioner Hunt?
Yes.
Commissioner Mark?
Yes.
Commissioner Mitchell?
Yes.
Commissioner Smith?
Yes.
Vice Chairman Booker?
Yes.
Chairman Jones?
Yes. All right, Vice Chair Booker.
Okay, so what are we doing right now?
Mr. Vice Chairman, I think the board needs to make and approve a motion to excuse the chairman from considering item 3B.
So
Okay.
moved.
Second.
Got a motion and a second. All in favor?
Aye.
Aye.
Okay. Now,
Now you can move on to actually considering 3B.
okay, so to do that, Mr. County Manager, I'd like to have Ms. Leslie Allen and her assistant come forward and explain to us exactly why we're doing this, what we're doing.
Good morning, Board. How this began was on Wednesday, March 20th, to an assessor's email list. An email came from Jeremy Akins, the Alamance County Tax Administrator, reaching out to all of his peers throughout the state. I received that email asking if we'd had anything where we had a couple of elected officials question a gap bill, because he had two. And he thought that was kind of odd. That was on March 20th. The next day, on the 21st, that afternoon, all the assessors on this email as well received an email from Department of Revenue, Travis Isaacs. Now, Mr. Isaacs works in the Personal Property Division and oversees motor vehicles, okay? And he explained to us, which you have the email in your packet, that he and Department of Motor Vehicles quickly contacted each other and discovered that in an improvement they were trying to make in the process of renewing specialty plates, and in improving came something of a computer glitch. And Jeremy Akins actually said that both of his elected officials showed the receipt where they had paid their renewals in December. Okay, but they got charged a January gap bill that should not have been created because it was paid in December. So they discovered and found that common denominator. So immediately, once I received the email, I recognized that and forwarded the email to County Manager, Mr. Vite, and just sort of waited out because I had not had any elected official approach me, okay? And as time went on, March 26th, which I believe you have in your packet there, Mr. Isaacs instructed all the assessors that if any of these elected officials did receive the bill, that I am to request either a release or a refund. And that's why we're here this morning.
So we have other tax refunds on this agenda, but we have several of the county commissioners who are going to get a refund because they were double charged. Is that simplified?
They weren't so much double charged as they were charged with a bill that should have never been
Shouldn't have been
created.
charged. Okay. So anyone have any questions for Ms. Allen regarding this?
I'm one of those commissioners. I didn't
Just
get it.
county commissioners.
Yes, sir. I have a list from Mr. Isaacs. I had him itemize every elected official as to why this elected official received a gap bill and this did not. And it's a bit of a list, but I'll be glad to provide it.
Yeah, I had called up in the beginning, so that could be why I didn't get it.
Yes,
Yeah.
sir.
So, Mr. County Attorney, now we need a motion to approve the refunds as stated in our packet.
Yes, sir. You can approve the whole report. And I will note, for the benefit, I guess, of the general public, it's not just county commissioners that were charged.
Other officials.
It's all kinds of local elected official.
Right.
It looks like almost like a local election ballot, to be honest. So, yes, sir, you can approve Leslie's request, the whole thing. You don't have to carve out the elected officials from the non-elected individuals.
Okay, so do I have a motion to approve? A motion and a second? Okay, we don't need a roll call on that, do we? We do. You'd like a roll call. Madam Clerk?
Commissioner Howard?
Yes.
Commissioner Hunt?
Yes.
Commissioner Mark?
Yes.
Commissioner Mitchell?
Yes.
Commissioner Smith?
Yes.
And Vice Chairman Booker.
Yes. Okay, the motion passes. Thank you for the explanation, ladies. Have a great day.
You as well. Thank you.
Okay, now I need a motion for the chairman to be
Restored.
restored to his position.
Yes, sir.
Second.
Okay, restored, second. All in favor?
Aye.
Aye.
Okay, motion passes. Thank you.
Thank
I
you.
think I understand what we just did. I'm not sure.
Well, you did it well, Mr. Vice
Well,
Chair.
thank you, with your guidance.
You did it well.
Thank you, Vice Chair Booker. All right, departmental matters. The first item we have before us is Social Services, the Adult Services In-Home Aid Budget Amendment. Mr. Merrick, good morning, sir.
Good morning, Chairman, Commissioners, County Manager. We bring before you today a budget amendment asking to increase the funds and through our home care, community block grant, and state in-home funds. What these funds do is that they assist individuals with in-home aid care that allows them to remain in their home instead of to be at risk of institutionalization. This, like many other funding sources in government, the need has continued to increase, the fundings continue to stay flat, and the cost of it has risen. We've outlined that in our packet. These are individuals who are age 60 or older. They are not eligible for Medicaid, so we always try to use that program first and foremost. But as again, they are not eligible for that. So this is another program that can help assist them with, helping with activities of daily living, that simple as bathing, helping with general house cleaning, things such as that. We've given a couple of examples in our packet, but we would ask that, there is going to have to be some decisions in regards to services being decreased, and that could include individuals having to be taken off of this program. And, we would ask that some funding be extended so it wouldn't be in such a short time frame. We were hoping that attrition would get us to where we need to be. However, that did not happen, and that's a good testament that the program's actually working. It's keeping people in their home and in relatively good enough health to where they're not have to go to a higher level of care, such as an assisted living facility or a nursing home. Which it would probably end up that if they would spend their resources down, then they would very likely access some of those services to where the counties would probably be paying more funds than they would here in this program.
Okay, Commissioners, you have questions or comments for Mr. Merritt?
No, sir, I move that we approve this budget amendment.
Okay, we have a motion.
Second.
And a second to approve the budget amendment in the amount of $60,000 for Adult Services In-Home Aid Program. Is there any discussion on the motion? All right, County Manager.
Commissioners, I've spoken extensively with Mr. Merritt about this, and this is a bit unusual. This is not something we've done before, but Jeff made a great point, and I think it needs to be considered here at the very end. If one of these individuals loses the service through this program, and they can no longer live at home, and they qualify or unqualify for Jeff's other services, you may pay a much larger amount for that person to enter a facility for the same care you're providing at home. One of the goals that Jeff and I have worked on since he's been here is to keep people at home as long as they can. By providing these in-home aids and basic level hygiene and nutrition, those services, quite frankly, reduce our budget by great lengths, which you're going to talk about in a couple weeks. So I would highly encourage you to continue this. It is unusual. We've never done this before because we've never, as Mr. Merritt said, been in a position where we haven't seen the attrition program, which is probably a good thing. I just want to say there's another cost here if this doesn't happen.
I can add on to that. For instance, if someone went to an assisted living facility and they spent down their resources and they received special assistance, that's approximately $650 a month. So you're looking at, what's that, $7,800 a year just for one person, which is over 10%, for these costs. And we have approximately over 40 individuals receiving either home care, community block grant funding, or that special in-home funding, which doesn't come out of special assistance.
A question just for the people who are listening in. For people who have to go into assisted living, i.e. if they no longer qualify for this program or if the funding for this in-home program is reduced, what is the average monthly cost of assisted living for one individual? Ballpark.
The ballpark, I couldn't, Commissioner Mitchell, I don't know what the private rates are. I know that with a special assistance that the state pays half and the counties pays half. I think the maximum cost that someone could apply for is $1,377 a month, $1,377 a month, which the counties pays half and the state pays half. But the private rates, I couldn't really tell you what a private room would cost. It was much higher than that, I presume. I mean, you're talking probably at least double, probably triple a month. Yep.
I just have a question, Jack. ECOG had a group come by that basically did this and present to us, and we talked about it. They're a statewide group, and if you pay into their system, and it's a monthly fee, they take care of keeping folks in their home. And it seems like exactly what we're doing here is what the group does statewide, and I'm trying to think of the name of the group that came and presented to ECOG maybe 4 months ago.
I'm not familiar with any program like that, Jeff. I mean, okay, I wonder if he's talking about the facilities getting built out by Bosch.
PACE, yes.
PACE Center.
Right, yeah.
That's go ahead, Jeff.
Those are Medicaid-covered clients.
Okay.
Mr. Howard, yes. So those would not be these individuals.
These folks are kind of in between.
They're kind of in the gap, even with Medicaid expansion, because we do try to come and, reassess them since the increase in the federal poverty level. But yes, the PACE Center would be to where it would be all-inclusive to those who would be Medicaid eligible, yes.
Thank you.
That's right.
Okay, other comments, questions?
Jeff, did you mention there's been a significant cost increase in this program?
Yes.
I mean, and it's just like anything with inflation. We were paying $16.67 an hour roughly in 2020, 2021, and now we're paying $26.20 an hour in 23-24, and that's market driven, right? For in-home aides, we don't have these as employees; they're all contract. So we've seen significant rise in the cost to provide those services. And I don't know that that's stopping now. I mean, I can't.
No,
say that.
we're actually anticipating. We've gotten costs for next fiscal year, and they're increasing as well too. So.
I know, just point of just stated that I've contacted you in the last year, probably more so than I have in all the years of my service, about calls that I'm receiving from citizens about concerns about adults that are home, nobody to help take care of them. Community folks are trying to come in and do it. We're seeing more and more and more of that in our county, and it's a great problem. I don't know, on the state level. I mean, is there attention being, I know it's got to be happening in other counties too. I mean, is there attention being drawn to it on the state level and General Assembly? Do you know of any kind of solutions at hand?
I have not heard of any other funding sources that's going to be coming for helping to fund adult protective service workers, guardianship workers. I have not heard of any other increased funding since the ARPA funds have gone away that's could be attributed to funds such as these. I think that there is discussions. I don't know how far along the line they are with solutions. I mean, you speak about it in our county, Chairman Jones, last year, calendar year 2023, we took 625 adult protective service reports. The year before that, I think it was 400 and in the low 480s. That's 21% increase. And while it's early through the first 3 months, we're on track to take 624 more in those reports. So we're seeing our numbers increase just like we are across the state. I know our association, one of our always in the long session when they're doing the budget is always trying to increase that funding for counties because here, once again, just like in child welfare that they told you, the largest funder of these child protective services and adult protective services is from essentially the smallest tax base, the county tax base. We pay the largest cost of administrative funding for child welfare. We pay the largest administrative cost for the funding in adult services and our adult protective services and guardianship programs. And it is something that hopefully that our direct association, maybe the County Commissioners Association can come together on and try to help alleviate some of that fiscal burden for our citizens from their local taxes.
Mr. Chairman, we've talked about it, and I don't, Jeff wasn't here the entire time, but starting in roughly 2012, the home care community block grant was greatly reduced multiple times. And we struggled here as a county. Many of you, I think Commissioner Mark was on the board for some of those. We had to reduce services multiple times, and we've continued to do more with less every chance we get. And one of the points we've made to our federal delegation is these funds are so vital. They're so vital. This should be one that's increasing, not decreasing, particularly in a community, in a county like Craven. And there are others in North Carolina across the United States that have the same population demographics that we do. But it was about double what we get now when I first got here, and that's been roughly 14 years. So we're doing what we're doing with half the money now.
What is the average age?
I would have to let you know that, Commissioner Mark. We'd have to go through and look at each one of our clients, but the minimum age is 60.
Okay.
But I mean, we've got individuals who are in their upper 90s, to people all the way down to 60s.
Because in the population we're talking about, people are living longer, and therefore the figure is going to go up, and up.
And Commissioner Mark, you bring a great point. They're living longer, and they have less resources and less safety net than they did. And that's one of the challenges Mr. Merritt and I talk about all the time is we run across individuals that have no safety net, right? So this limited amount of resources for someone to come in their home and help with some basic life functions is absolutely critical.
Yeah, just a couple things. Number one, there are thriving businesses today. One of them is owned by one of my friends called Help at Home, where he has like 40 people that work for him. Some are nurses, some are like nurses' aides that go and help people, everything from shopping to their health needs, medication, all those things. But I guess my other comment would be that as people age and they want to stay in their home, and I think it's a couple reasons. Number one, the cost of going to a nursing home today is astronomical. Going to any kind of facility where you're getting full care, it's crazy. And there really aren't a lot of space. There's not much space available in our county. The second thing is just a reluctance to say I'm going to leave my home and go live in a group home. I don't mean a group home mentally, but just a nursing home. Like if you're on the railroad, you got a bunch of stops along the way in your life, and that moving to a nursing home is like the next to last stop, right? And people are resistant to do that, to give up their independence. So I think this is critical that we do everything we can to keep people in their homes.
Yeah, and some of the people you're mentioning that have that are spending money also. and having these people come into their homes.
Yeah, well, yeah, sure.
All right, any other comments? All right, we do have a motion, we have a second. Hear no more discussion, Madam Clerk, if you will, call the roll, please.
Commissioner Howard?
Yes.
Commissioner Hunt?
Yes.
Commissioner Mark?
Yes.
Commissioner Mitchell?
Yes.
Commissioner Smith?
Yes.
Vice Chairman Booker?
Yes.
Chairman Jones?
Yes.
Thank you.
Anything on Medicaid, no, nothing new, all about same?
Well, Medicaid expansion, we're still right around the 500 or so mark in the number of applications in the queue that we may be getting to our new normal. But I know our staff are working hard. We've had some turnover like all counties, but we're trying to fill those positions again. It's hard when it takes from almost the perfect scenario would be 9 months for someone where you post a position and you hire and you train them. Realistically, you're looking at about a year. That's just how complex, learning that program is in our software program. But our staff continue to work hard. The county manager and I have tried to come to solutions to help them keep us caught up on work as much as possible. We are seeing some challenges in regards with the Medicaid report card. I know there's many counties who are filling that right now. In the past, it was, before Medicaid expansion, they didn't. I was talking to my income maintenance administrator, and I think there was only one time they had ever heard that we failed it before Medicaid expansion. And that's where they look at the number of applications and timeliness. So we are seeing some struggles there, but we're trying to come up with solutions to where hopefully we can, once we get some more staff and get them trained, where we can catch back up and do that. We did fail in February too, but that was because NC Fast wasn't working properly for approximately, I think I put it in your report, 4 days out of the month, something like that.
Okay.
Yep. Last point would be Mr. Assistant County Manager. I was at his facility last week, and the walls are going up on the new addition. So that's exciting to see.
Yes.
Yep. Slabs poured, and that steel should be coming soon, so you'll really start seeing it go up here in a little bit, according to our report. Getting that right, Gene?
All right, thank you. Appreciate you and Jeannie.
Thank you all.
What you do. All right, next item we have before us, item 5, is finance. Mr. Craig Warren. Good morning, sir.
Good morning, Board. How are you?
Good.
I have one item on the agenda this morning, and that is the consider approving the public school capital fund application. Each year, the Board of Education and the Board of County Commissioners jointly approve a project application to be submitted to the North Carolina Department of Public Instruction. This application is required in order to draw down the lottery proceeds that have been allocated to Craven County by the state in the Public School Building Capital Fund. These funds are restricted and can only be used for school construction projects or to retire debt service incurred as a result of school construction projects. These proceeds will be applied to the current year's debt service payment of approximately $1.4 million. That will be paid on the 2013 limited obligation bonds. These bonds will retire in fiscal 2027, actually December of 2026, and is the last remaining debt on the county's books for the school system.
All right, Commissioners, what's your desire?
Make a motion that we approve the
Application.
Second.
yes.
Okay. We have a motion and a second to approve the application. Any further discussion on the motion? Hear none, roll call, please, Madam Clerk.
Commissioner Howard?
Yes.
Commissioner Hunt?
Yes.
Commissioner Mark?
Yes.
Commissioner Mitchell?
Yes.
Commissioner Smith?
Yes.
Vice Chairman Booker?
Yes.
Chairman Jones?
Yes. Thank you, Craig.
Sir.
I think our next item, we're going to have probably going to take us a little time. I'm going to go ahead and ask, let's take about a 5-minute break, and because when we come back, we'll be in here probably for some time with that. So about 5 minutes. We'll come back to order. Item 6 is the opioid epidemic response. I'm going to turn this over to the county manager, let him do some introductions this morning.
Chairman, thank you. Really excited to have with us Corey Richardson, Dr. Richardson from ICGH. I've said that wrong 3 times today, so I'm finally glad to see in front of me. Dr. Richardson, someone I met over the last couple months and working with Carteret County on some new facilities that they're opening up. I asked Dr. Richardson to come this morning and brief you on his company, but also some of the programs that are already going on here in Eastern North Carolina. So Dr. Richardson, the floor is yours, sir.
Thank you so much for having me this morning, and I appreciate it. And that is true. I'm here today mostly because of the Carteret County partnership that we've had in opening the new behavioral health hospital that's we'll talk a little bit about, and the available opioid settlement funds that we're already using regionally we're already using. So I'll try to be as brief as possible. It's a large slide deck, and I have dropped off with the clerk some informational that you can have afterwards. And then on our website, there's an expanded talk around our services. But go ahead. And I usually have a clicker, so I don't have to do this, but go ahead again. I would like to just keep it a little bit more brief so you can have some Q&A later. We have an expansive number of services for adults, and that goes from comprehensive clinical assessments all the way to EMDR, et cetera. Let me preface, because I know you've had a long morning already. In Hickory, North Carolina, we started at a small, long-standing medical practice back in the 70s, family-owned. Over the years, it reincorporated to PCMH, which was a patient-centered medical home, which incorporated behavioral health alongside of medical services. And during the opioid crisis, we became a corporation only because the partners, the MCO, reached out to us asking us to expand our locations in that catchment area. Subsequent to that, there were a lot of opportunities because of the quality of care that we were delivering, and we were able to start securing some of those federal grants. But I think some of the difference is we're not a bigger corporate operation as much as really strategic focus on addressing community needs. So we really do create our programs, interventions related to our programs around needs. And so some of these programs that you'll see right here, we really organically come to the fore. So EMDR, so a lot of our services that we provide, including recovery housing, transportation for recovery-focused services, the higher levels of care like IOP, and then some of those other community interventions that you might look at like peer support training, RAP training, referrals as well. If you'll go ahead, we'll look a little bit at our adolescent population. And we were talking earlier about some of the needs of our adolescent population. And while some of these are basic services and much needed, if you will, we want to go ahead and talk about some of the other types of things that we're starting to identify more because of more substance use in that population at a younger and younger age, as well as the fallout from the opioid crisis. We're having more children enter the foster care system. And so we're identifying, if you will, the need for higher levels of care like trauma-focused CBT. Earlier, the DSS CPS presentation was talking about the difficulty of placing children with behavioral. And very often it's just undiagnosed complex trauma like sexual abuse. And in our communities today, we're seeing these children are not just difficult, they're untreated complex trauma. So children as young as 3 years old can start to get the needed interventions so that they can be placed and they're not just cycling through generational addiction and generational mental health problems. But identifying these at earlier and earlier ages, you get better outcomes, if you will. And this is just some of the criteria around treating children that are very young. And this really dovetails very nicely into our hospital, behavioral health hospital, up in sea level because there will be an adolescent inpatient wing. Go ahead. Let's talk a little bit about substance use disorder and the model that we use, which is a little bit different. And we've always incorporated this even before there were peer support specialists. It's a recovery-focused model because sometimes you have a therapist and you have medication and you might even have a group session, but there's a lot of time in between all of those. And so early on, we tried to figure out how we can have higher levels of intervention without higher dollar amounts. And the county manager was talking a little bit about doing more with less. And so a 12-step facilitation model is exactly what that does. And we've always hired and trained people with lived experience to be counselors and to guide in that process before there were peer support specialists, which is a more formal training that we also do at this time. But that alone is not sufficient, so that we add medication management like regular behavioral health meds, medication-assisted treatment like Suboxone, as well as other types of interventions like EMDR, trauma-focused CBT, all the other types of interventions. So you get more of a matrix model of treatment, if you will. So a lot of times some of these organizations will pack rooms, and if you have a smaller size of a group setting, you can have a higher level of interaction with those and a higher level of therapeutic alliance, and available counseling schedules, a little bit more flexible than just when we have it in our office when we need it. And so, as you can see, there's a need for a higher level of interdisciplinary interventions. So we have our own pharmacy, we have our own toxicologist, we have a variety of levels of care, and then it ties to our recovery housing. Over the period of time, we noticed that Medicaid and Medicare were not sufficient, as well as private insurances. And before Medicaid expansion, we started to seek out and secure a lot of large federal grant dollars for those that there are a lot of the gaps in care. Those grant opportunities really did drive a lot of the strategic interventions, such as resource navigation, recovery housing, outreach to the encampments, and I'll talk a little bit more about those. But those have all been federally funded programs that have never been really funded enough by the state. Only recently have we been able to secure state opioid response dollars. We have relied on HRSA dollars, SAMHSA dollars, BJA dollars, and other dollars like that to meet all those gaps in our program, if you will. A variety of licensed providers, not just certified providers, if you will. And a variety of medical providers, not just 1 day a week, but 5 days a week, and as needed, if you will. Talk a little bit about medication-assisted treatment. A lot of times, if you look at medication-assisted treatment, there's a good way and a bad way to use it, kind of like our sheriff here, using a gun. There's a right way and a wrong way. In our program, we have really used medication-assisted treatment as it was intended to help stabilize and then really lean heavily into the behavioral health interventions so that they can learn the drug-free coping skills, and then they can move forward with all those other types of social supports that they need around literacy, around employment, around housing, around food scarcity. And until you work with this population and you have a mother of 2 or 3 that cannot sign her own name, then you realize that what we're doing around a prescription and see you next week is just simply not enough. And so those are the types of things that we've been able to really do. And that's really driven our program in ways that is not because of remuneration. It's because of it's needed, and this is the only way you're going to get the outcomes that you need. And that's why we've been able to secure multi-million-dollar grants because of the interventions that we do. And we've just taken these really quality programs and just continued to expand them across North Carolina, predominantly in the rural communities, but also in some urban areas like Estonia, and in particular with some of our newer problems around homelessness and certain types of underserved populations. But medication-assisted treatment is great. It saves lives. It's evidence-based. But it is only a way to get people started into our program. And then once they stabilize, we do want to encourage people at different levels to slowly titrate off this medication so they don't have to have a doctor if it's not necessary for the rest of their life. Go ahead. A lot of times we found that there's a lot of stigma, as you know, around addiction treatment, and we're trying to fight against that. Sometimes even with providers, like pharmacy providers. So early on, we realized that some pharmacists in those programs were stigmatizing our patients and not delivering the same level of care. We opened our first clinic-based pharmacies and then expanded to retail pharmacy so that people could pick up their prescriptions with us. We could also deliver those with our mobile services, no matter where they were. And then for those pharmacists, for those clinics around North Carolina that did not have the support of pharmacies locally, kind of like Lumberton, North Carolina, and other rural areas, we actually partner with those clinics to provide their pharmacy services. Go ahead. So these are a lot of our grant and state-funded programs. There's a lot of those there: free peer support training, free peer support direct services, provider training like the Northwest AHEC, free opioid treatment around MAT services, recovery housing, transportation. Go ahead. I'll go ahead and get into a little bit more of the specificity of that. Our current federal and state programs, as well as some county funds around just free treatment for those. And as Medicaid expansion has been very helpful because we have peer support specialists that really become community navigators. They're peer support specialists, they're community health workers, and they're SOAR SOAR certified. So they're able to help with the enrollment in Medicaid services. And so while we've been able to shift some of those needs into Medicaid, we've been able to bring some of our other budgets into expanding our recovery housing, our recovery transportation, and our other services like parenting, life skills, and the other types of programs that we have to fund. So we do lock boxes in various areas, deterra bags, rescue Narcan, harm reduction, a lot of educational opportunities through Northwest AHEC, where the crisis intervention training with partners, behavioral health management. So there's a lot of great federal and state dollars, not just around treatment and not just around recovery housing, but really at the community level around like PSA, TV ads, and billboards. I'll show you some examples in just a minute. Go ahead. And this is one of the last grants we have, and this is pretty routine with our program, is that we've been able to identify needs in North Carolina, seek out some grants, kind of like we've been talking to your county manager now about, and then secure those grants, and then successfully make sure that they're delivered appropriately. And we always use an outside data evaluator, so not just believing what I say about our program, but our data evaluators are really kind of challenging us, partnering with us to make sure that our outcomes are accurate. And so our data evaluators are NC State University, Complex Systems Innovations, and others. Go ahead. We do a program around pregnancy, and we've done the program, especially a MAP program, Medication-Assisted Treatment Program around pregnancy, before the hospital. One of my very first referrals into my program was a young gal with twins. And the UNC Mother Study was around, but there was a lot of hesitancy around medication-assisted treatment, even though the literature was very clear that medication-assisted treatment gets that woman to the delivery room, gets that child to the delivery room, and then the titration off of any medications in the NICU, no long-lasting effects. So we're very proud of that program, and one of our first pregnant women going through our program was a nurse, and she still partners with us to help women go through that process. Because even in our hospital settings, if you are pregnant and you are drug addicted, there might be some stigma from the care that you get from even the nursing staff. And so I often say to people when we talk about adults with mental health or addiction, keep in mind this is a disease that's between the ears, and we often think that we can make really good decisions, but if you were hit with a baseball bat or if your blood sugar was 400, you may not have the ability to think clearly to make good decisions. And a lot of people that enter recovery and go through a period of time, and really not just neurotransmitters, not just drug levels, but brain structure takes exactly 2 years to get back to normal. If you look at a functional MRI and you look at the brain scan, it's not working even close for the first 2 years. So we try to give them a safe environment. We give them safe resources. We connect them with a peer support that's gender specific. And we give them all those other things during that process so we can get to that period of time where their brains are a little bit more clear. They can start to work with the prefrontal cortex, that's been hijacked, the limbic system. And what happens and I have a whole other presentation about the brain disease, but honestly, if you look at people with a substance use disorder, their brains do get hijacked because not all of us are allergic to peanuts, but some of us have an unusual response. Not all of us are allergic to bee stings, but some will die from it. Some people will use substances and you can shut down the brain. So it becomes hijacked, and the mesolimbic system, it literally recalibrates and thinks of drugs as survival. And when they get clean and sober, they look back and they say, I can't believe I ever did it. They become the best parents that you would ever imagine. They become employable. They become some of the, your citizens that you want in your community. And we sometimes forget that, and the stigma of that mother who's actively using, and she's looking at drugs as survival more than taking care of her kids or housing or showering or taking care of her just activities of daily living. We need to understand that this is just similar to somebody who's schizophrenic. The brain is not working the way it is. And what we're trying to do is offer all those interventions, not just a prescription, not a little talk therapy, all the interventions that are needed to get the outcome to turn their life around. Next slide. So this is a little bit more our pregnancy support. Our nurse that went through our program still works with us. Go ahead. And I was on the opioid panel with the governor. He had a panel back in 2018. There was no real good Venn diagram, so I created this, and I do share it nationally through a listserv of physicians and addiction. But the idea of any medical condition is that it's a biopsychosocial, spiritual type of thing. Even diabetes, right? You have the biological one, you got the behavioral one about diet and exercise, right? And you got the social interventions. If you don't have money to buy your insulin, you're probably not going to get a good outcome. If you don't have a good grocery store near you, right? So there's that social piece. Then you're probably going to have to buy some processed foods. You're not going to buy Whole Foods or all those other nice healthy things. So that's a biopsychosocial. And when I say spiritual, just keep in mind, I mean meaning and purpose. That's really what I'm talking about, the motivational factor behind it. Because if you don't have meaning and purpose in your life, I doubt you're going to get the outcomes that you want. So that's really what's happening here. There are some principles and there are some features around this treatment plan, but the idea is that disease has these components, these dimensions. So you have to identify goals with the similar types of dimensions, and then you have to find a treatment plan. But if you don't have all those interventions, you can't get those outcomes. I apologize if I'm going on. I really do. Next slide. Let me just go over just a little bit about us because you don't know us. We have a really strong footprint in Western North Carolina, and I think that's when I met with Dr. Williams like a year and a half ago, I think that really made an impact on him and allowed us to secure that facility. And he did share with me we beat out other competitors for that opportunity because we are a community interventionist program. We are not a big healthcare system that just bills claims all day long. We do things very, very differently. And we have a very good track record with our lawmakers, Patrick McHenry or Tom Pillis, our governor, teaching at Wake Forest School of Medicine through Northwest AHEC, community intervention programs. We create a lot of events as well. I'll talk a little bit about that. Next slide. The faith-based community, I think we have a pretty good reputation when it comes to research. My primary research with the North Carolina Physicians Health Program is the only primary research with PAs and monitoring. And research like that really does guide evidence-based models of care. You can say you're doing good work, but if you don't have fidelity to models that are proven, then you're just talking a good game for people, and so you can send that claim out the door. Next slide. This is a big event. We've done several of these large recovery summits and larger events. This was in Gastonia last year. Very proud of some of this stuff. Brought a lot of amazing speakers to Gastonia last year. Recovery housing, I just want to give you an overview of why we started. Back in 2015 there really wasn't any funding around recovery housing. Nobody would take anybody with Suboxone because of the stigma around medication-assisted treatment. Keep in mind, people don't get addicted to it. It's a blocker. People sometimes want to have some misinformation and kind of carry that over. But at that time, what we figured out we had to do is I took out a HELOC loan, I got some condos rented, and we started our own recovery housing. We funded it ourselves. And the idea was to give people a place where they could be on medication-assisted treatment that was helping turn their life around, taking care of craving, taking care of withdrawal, had no mood-altering effect, but they had to have an environment where they could be clean and sober. And that meant not under a viaduct, not co-locating with a bunch of other people that were in active use. And so that's where we did it a little bit differently. Today we have 78 beds across North Carolina of recovery housing. That's all funded by HRSA, SAMHSA, Partners Behavioral Health Management. There's a county sheriff's fund as well. So 78 beds, completely funded, recovery housing, great outcomes. And a couple of people who started way back when I first started my first one, have not left, but they pay their own way. They have really good jobs as supervisors in factories. They found out that this was a good fit for them, and they were later in life. They finally had a relationship with their mom. They finally had a relationship with their kid. They act as house managers or peer supports, if you will. But if they're going to pay their own way at a reduced cash rate and support others in that journey, that's a good fit for us. So this is some of our PSA TV ads and billboards. This is one of our billboards. And you'll look there. I created this billboard through some of my ARCOR funds. A real positive message around recovery, persons with lived experience in long-term recovery, like myself, like our medical director, like most of our staff on the addiction treatment side, that you can have a really good life in long-term recovery. And so I like this messaging because years ago you would see just a lot of dark, empty, hopeless images around addiction, and that's just not accurate with the right interventions. But you see, in this region, I didn't just put our information there, but I also put information to connect with other quality providers. So we're not just trying to promote our program, which I think we have one of the best programs in North Carolina. We're really trying to connect people with quality resources and try to keep them away from the predatory providers, the dose and go, the pill mill docs that became the Suboxone docs, that kind of model of care, which just keeps people locked in. We're trying to avoid that. From a lot of that messaging, go back one second. A lot of that messaging, we created some of the bags right there around some positive messaging. And these bags are going to our encampments and our shelters. They're going to specific programs with law enforcement, Gastonia Police Department, the Cleveland County Sheriff's Office. They can connect with people that they know that need these. And so maybe they don't want to get help today, but they have our contact information and they can reach out to us or one of our peer support specialists. And then go ahead, we fill those bags with a lot of these supplies. And I'm not filling these supplies only to make people live more comfortably out in the woods or live more comfortably in what should be uninhabitable, like chicken coops and stuff. Rural homelessness looks very different than urban homelessness. Abandoned trailers, abandoned cars. What we're trying to do is somebody in active addiction, connect with them exactly where they are with some clean socks or clean underwear or some hygiene or some toothpaste or something. But tell them when we're engaging with them, whether it's raining on them or it's cold, like, hey, you don't have to stay out here. You can come with us right now into recovery housing. And we have taken people out of encampments, sometimes men, sometimes women, in full psychotic episodes that are being absolutely abused in large encampments and don't know where they are or who they are. And if you can get them into the right program like ours, maybe a gender-specific therapist, maybe medication management, maybe some Suboxone, clean sheets, a shower, people to take care of it, it makes a whole difference. You wouldn't believe some of the people we've brought into our vans to get them into recovery housing that smell like a cat box because they haven't had a bath in 9 months. These are North Carolina citizens, and I feel they're our responsibility. And they have a disease between their ears, right? And so that's why I've been very successful at getting large federal dollars, is because sometimes it's hard to connect with people like you would want, but you can get some funds and you can do the work, and it's really good work and it's very rewarding. Go ahead, please. But in those bags, we also include a lot of information about rescue Narcan, lock up your meds, how to get help from us. We partner with the health department, so they'll give out some of that. We do a lot of screenings around Hep C. I'll tell a little bit more about mobile access, where we do medical units out there. But in the colder months, we'll put blankets and gloves. In the warmer months, it'll be bug spray and cooling towels. But the idea is to just connect with them. And even those people who aren't as bad off as others there's a lot of stigma there. There's a lot of fear. They don't want to talk to you. If you can just connect with them. One of my national talks that I just gave to all the HRSA R-Corps grantees was how to start your own recovery housing. We use peer support specialists who have not only recovery, but they've also had lived experience around being homeless. And if you can take somebody and you can work with them who used to have addiction and now is a peer support specialist, can share honestly and authentically about being homeless and can go out there and say, hey, you don't got to stay out here. You can engage with somebody and just give them a little bit of hope. And we never think it's going to be our kid or our grandkid. But I'm going to tell you, 15% of the population, right, is going to have addiction. And a growing number are now dying of this disease because of the illicit fentanyl coming across. So, one of our therapists, her son had no problem at all. All right, he went off to college. Somebody gave him something. She had to go get him in a body bag, right? We can make differences, whether it's prevention, whether it's harm reduction, whether it's treatment, and so all of our programs that we create, whether they're educational funded, whether they're treatment funded, whether they're building communities of recovery funded, they're really kind of very interlocking. This was a clip from Charlotte Today. They showed us on Charlotte Today at the end of last year. You can see one of our peer support specialists going into an obvious area where people are living day to day in North Carolina, bringing down supplies and then trying to take them out of there. That abandoned car, we know somebody was living there, but they go out in the day. Your sheriff will tell you sometimes they're going out to try to survive and come back to that car. We leave information there. And if we can prevent recidivism, if we can bring them in, so they're not out there dying in the woods, I think we can do some real good. We have such a good reputation that in one of the encampments inside of Gastonia, there was a murder because there was a lot of crime. The Gastonia Police Department called me on a Friday afternoon and said, will you be there Monday morning? We're emptying 150 people in an encampment. We're emptying it. We need you to help place them in detox or housing. I think we have a very good reputation there. We provide some of these programs inside of like Cleveland County's jail for Vivitrol and bed to bed. You go from the jail directly into recovery housing. You don't go to the dealer. You come directly. We work with peer supports inside the jail, talking to them, giving them support, talking to them about what could be the next step, and then picking them up upon release. Go ahead. I'm very proud of our resource navigation program. We have multiple contracts right now, sometimes urban and sometimes rural, around connecting people with resources. And this is everything from our mobile units, it is screening and testing, it's our computer labs, and it has everything to do with education, literacy, addiction treatment. You in Craven County, and I don't know your county as well as yet, but you might have some really siloed resources and people just don't know they're there. You fund them, but they're not there. So your county manager and I have had several meetings with Amber about siloed resources, and the idea of resource navigation is not just giving them a flyer to say like, hey, a lot of people aren't going to tell you they can't read, right? They're very fearful about calling anybody. What we do is we walk them through the process. Let's go to NC Works. Let's go to Voc Rehab. Let's go to that probation meeting, and let's go ahead and get this all tied up so you can get your life back on track. Let's support you. One of our peer support specialists went through DSS herself. She has amazing presentations she gives across the state around being a mom who went through DSS, went to prison, and came back. She's got an amazing home now from Habitat for Humanity. She's a program coordinator on our large federal grants. She works with DSS, talking about how DSS workers can work with moms who don't want to open that door for you because they're afraid. And that's the kind of innovative stuff we've tried to do in that. And when we don't get funding, we do it anyway. Go ahead. Harm reduction. Harm reduction is different for every community. Harm reduction has a bad rap because it's usually associated with needle exchanges. We don't do needle exchanges. But what we do is meet the community where they are. We try to save lives with things that we know that work. And that's also prevention of overdoses, like lock up your meds, get rid of old meds, like pill take back marketing and media. But we have harm reduction around us every day. We have seat belts, we have helmets, we have filters on cigarettes. We do a lot of stuff. But for us, harm reduction is about engaging somebody, saving a life, and getting them into recovery-focused treatment. It is not about safe use of drugs. I don't care how safe heroin use is, you're not getting your kids back. And so we try to reiterate that again and again and again, because a lot of things like medication-assisted treatment, mental illness, harm reduction, they have, there's a lot of stigma around that. And if you have stigma, you're not gonna have people reaching out. And so that's why I think it's important to understand fundamentally what things are and how they can be delivered one way or delivered another. But we're not talking about safe use. We're talking about saving lives. Thank you. Next one. This is a couple of our mobile units. We do a recovery bus. We have a couple of those. We have medical access. So not only are we going out to encampments, not only are we going out to shelters to do some of the actual delivery of medical services, but we're also treating chronic hep C, you know. And so it is one of the few diseases that we have now that are completely curable. But if you realize that somebody is homeless and they have a pet, they're not going to the health department. Mm-hmm. If you realize somebody is homeless and has a partner that's disabled out in the woods, they're not going to leave her. And so being able to be more mobile, especially when it comes to rural North Carolina, and we are very rural, and that's where a lot of our funding comes from, is addressing the problems in rural North Carolina. Go ahead. This is another PSA TV ad that we did around addressing addiction. I really like the idea of some really focused communities, and they dovetail very nicely with our billboard, our other messaging. We've been teaching at Wake Forest School of Medicine for about 15 years or so around integrated care, but most of my work over the last 10 to 12 years has been around best practices around OUDs. So if you called Dr. Jones up there at Northwest AHEC and say, who's your expert? Would probably say me, which I'm very proud of. If you go on Northwest AHEC and you just Google my name, you can search out some of my provider education, so we're AMA accredited, we're North Carolina Board of Nursing accredited, and our learning modules I think are great. They're very interactive for nurses and PAs and doctors. But we incorporate this with all of our federal grants around best practices. You've probably gotten a little sample of what we do. And so if you do best practices but you don't practice it, there's a gap there. And so what we try to do is teach best practices, improve on it all the time, year after year, deliver those services that we talk about, and then help other providers across the country with best practices. So, and we don't just do treatment services. This is a community program that we set up a couple years ago that really took off during COVID. There's a lot of stigma in even the 12-step community around medication-assisted treatment. And so what we offer is a true, authentic 12-step program, even if you're on medication, that you can talk about the 12 steps or God or higher power. I did figure out that I left one of our nonprofit slides off on the drive-in this morning, but we do have a nonprofit called Recovery NC. We get large funds around from United Beverage and others to fill gaps, and we're very proud of our partnership with United Beverage because they realize that not everybody can drink, but they do fund some of our programs for those people who are struggling that don't have funding streams. While we have a lot of dollars for opiates, we tend to forget that over 100,000 people will die of alcohol-related deaths in America this year. Go ahead. Just about me, and just about my medical director, and why I'm in the Outer Banks and why I'm here in Eastern North Carolina. These are the programs that are coming online at the hospital out in sea level. At this point, we're really just refurbishing it. There's a lot of work that has to happen on things I never thought about in my life before, like boilers. If you would have told me I would have been working with boilers, I would have thought you were crazy. Generators, backup generators, and everything else. It's an amazing facility. I'm very proud to be out there working there, right there off the ocean. And we're going to have a hospital in your neck of the woods that's not going to be like anything else in North Carolina. We're going to do facility-based crisis and detox, residential for substance use disorder, and those are for adults. And we're also going to be adding an inpatient adolescent mental health wing as well. And that's going to address some of the problems that we've been talking about. While you have children that are hard to place, it's because they have undiagnosed complex trauma. They have untreated complex trauma, including sexual abuse. And we're going to be adding trauma-focused CBT, cognitive processing therapy, for those who have co-occurring, which includes substance use disorder, intensive outpatient along with that, and giving them a safe place to live. We'll be adding some of our outpatient services I've talked about today. And then along with our facility-based crisis, we'll be adding IVC after the stabilization of the first delivery of services out of facility-based crisis so that your sheriff's office and stuff, they don't have to sit in the ED for 12, 24 hours and try to find somewhere to go. They can bring them up to sea level. Next slide. And this is Craven County next to Carteret. And go right ahead. This is obviously a slide you know better than I do. These numbers are take anybody back, and that's why I'm here today, and that's why some of the funds out of Carteret County's opioid settlement dollars have been determined to be regional now. Is Dr. Rhonda Williams at the health department said that we were going to provide any of those opioid services that we're providing in Craven County as well. Go ahead. And this is what we are currently offering in Craven County to address the opioid crisis that you're facing. So free Suboxone with drug testing, free counseling including intensive outpatient, free recovery housing in Carteret and any of my recovery housing in West North Carolina, and hopefully we'll be able to expand a housing program here. Recovery-focused transportation, free coordination of care and resource navigation, and free outreach and awareness campaign. So working with Amber and to devise the best strategic plan to move forward. Very great meetings around what you're doing here and how we can support you in that. But these funds are all available from Carteret County and Dr. Rhonda Williams and Tommy Burns. Next slide. And then some of the things that we would like to talk about, I think your county manager and Amber, part of your opioid team, thought that maybe this is some of the stuff we could do. And I can turn it back over to the county manager any time, but it may be expanding the regional coordination of resource navigation, maybe supporting your post-overdose response team. I do a lot of port teams, bridge MAT programs. It means that somebody's at a rescue and now you need to figure out where the provider is. You don't want to like hand them a piece of paper and say like, good luck, there's a provider downtown. You want to be that person. So we do a lot of these programs. Coordination from seamlessly taking care from the EDs, where a lot of people are presenting either they're looking for a prescription or it's a rescue of an overdose, right into services. And then of course we like to expand access to the ICGH inpatient services up at sea level. So next slide. A little bit more. We are pursuing some federal funding around substance use and mental health initiatives, and there's some really strong funds that were just released, and we're talking to your county manager about that. These are vulnerable populations such as unsheltered persons, pregnant women, justice involved, children and adolescents, and then addressing some evolving threats like fentanyl and xylazine. That's around service delivery, workforce development, provision of support services, and ensuring long-term sustainability. Those are some of the goals I have on a couple of different grants that I'm working on currently that incorporate, that are for Carteret County, and I would like to incorporate Craven and Pamlico and Jones. Next. And one more slide. That's some of our companies, our nonprofit, our community agencies, and final slide. Thank you so much. Sorry about the final slide thing. I'm used to clicking the whole time, and I apologize. More information on my website, of course, and I've gotten some media packets for you. I really appreciate your time. It's very valuable, and it's a lot of information. If you have any questions or if your county manager wants to take over, I'm available.
All right, Commissioner Mitchell.
Dr. Richardson, thank you for such an informative treatment program. I was lucky enough to get sober in Washington, D.C., and we had the wife of President Ford, who de-shamed the issue up there with it, and I've been clean and sober 26 years.
Me too. July 14th, 1998.
Congratulations. I got you beat by about 6 months.
Yeah.
With it, but I wanted to clarify something. Your presentation focused very much on vulnerable populations,
yes,
which we have a lot of in Craven County. I would like to clarify, are these programs at sea level going to be available to people who aren't homeless, but who are living in 4-bedroom houses?
Yeah, so, and one of those slides I was racing by says we take every insurance under the sun.
That's what, right, that's why I was asking for clarification,
Yes,
so that the citizens in this community understand that sea level would be available to everyone.
Absolutely.
Okay.
There's a need to make that access. So that's one of the goals of this talk today is informing you about sea level as we come online, which would be probably 60 to 90 days because all the licenses are being reviewed and we're working with DHSR around the facility requirements. But all the applications have been submitted, so we know those will be some, but really it's about increasing access too. And I want to thank you for sharing your recovery, because they look at a county commissioner and they say, she can do it. It's around destigmatizing things.
Right.
That's really what it is. It's around just destigmatizing it. And if we can't be transparent, and I know that everyone has a right to their privacy, and I absolutely believe that, but some of us are very comfortable in this space to say, like, and for me, working with people who are just like, and I work with physicians and nurses and judges and attorneys, just like I work with people coming right in out of encampments. So for me, it's a very important part of the work that I do, so that, you know, the next generation can say, like, hey, I think I got this. Can you figure out if I got this disease called addiction or not? And can we, because earlier treatment means better outcomes.
That's right.
You know, but if you hide this disease, you die from this disease. But absolutely, it's absolutely available to everybody. We take every kind of insurance, and we're going to absolutely be dependent on that. But we also work, and with Medicaid expansion now, it's even better. But even when we didn't have Medicaid, a lot of these services were still available. Children still were available because they have Medicaid for children. And then for the uninsured population, around like detox, facility crisis, you still got the MCO that was covering it. So these are absolutely available to everybody. But we will add residential. And so that would be a more of an insurance-based for people who have those nice homes that we're looking at purchasing right now in Beaufort. So, yes.
Anything else? Commissioner Hunt.
A couple things. I've been looking forward to hearing your presentation. Thanks for coming to Craven County. Appreciate it. One of the things that I appreciate about your programs is the warm handoff for recovery, and so many different steps of the way. I think it's crucial to complete and long-term recovery. But as an advocate for being pro-life, I'm not just pro-life when the baby's in the womb, but after the child's born. So could you talk a little bit more about the services you're going to offer our adolescents? How young will you go?
Yes. So to your first point, that's the problem with a lot of the detox programs. I'll detox you. I'll put you right back in the same one, and I'll see you 2 weeks later.
Right.
And I'll keep detoxing you until you're dead.
Right.
That's the problem. And so, and the other problem that we see, and I don't know about but at least in West North Carolina, there are providers that think that you can put people in detox like it's a jail, and they treat them like they're in jail. And so when we're trying to make a referral for somebody with alcohol withdrawal or benzodiazepine withdrawal or whatever, they're not going. They'll say, I'd rather try to just get through it at home by myself because they treat me so badly there. And the lobbies look like a crime scene. And so, they're not going there. So the only reason that we have expanded in this direction is that there was not that quality level of care that we saw that had to happen. So we are going to be able to provide that from encampment, all the way up to the highest level of non-hospital medical detox. But that's why it's so important for receiving them from detox or receiving them from jail or receiving them from substance use disorder inpatient right into recovery housing, because otherwise they're going to fall right into that gap of the old environment. They don't know where else to go. And we get a lot of referrals directly, just as involved referrals from prison as well, because otherwise they're going to go right back to the same community. They're going to do the same thing again. So that's a very good point, that these providers will make as much money as they can, and they're really not concerned about, they'll talk a game around discharge planning, but they're not. We have the houses. We're going to connect them with others in the community like Mission that have housing, that are going to give them the support and anchor them in these. And you can anchor them with medication, you can anchor them in peer support, supportive employment, and all those other things that they need without judgment. So with children, our plan for the adolescent wing and inpatient program up in Sea Level is from 12 to 18. Okay. We do have some programs where they age out at 18, they can go into some of our recovery housings, but we don't have that recovery housing for them here. It's HUD funded back in Catawba. But, and so I'm not sure if we're able to replicate that, but sometimes children will age out at 18 and they don't really have enough of the supports to go on by themselves. And as I described, some of the interventions that are needed for this population are going to be trauma-focused CBT, if they have a guardian ad litem or parents that they're trying to re-engage with, it's not the perpetrator. Cognitive processing therapy, if they don't have anybody at all. And if they have co-occurring, it would be IOP. Now, our youth program, trauma-focused CBT, you can start children as young as 3 years old. If they can verbalize the incident, if they have a memory of it, they can verbalize it, they're not living in the home with the perpetrator. There's some really clear criteria there that you can work with them. But very often you can work with just the parent or the guardian or the foster parent, not working with the child, and still get better outcomes because it's how you interact with a child who's been horribly traumatized because of abuse. So.
Will you be offering those types of services at Sea Level facility?
And we'll be also expanding our school-based program as well.
How many children will you have? How many beds for children?
Well, there are some negotiations with DHSR around the facility license, and so I will be transparent about that. We would like to offer our communications with DSS and the school system in Carteret County around their immediate needs was a lower level of care because there's a higher need. But that usually is a freestanding facility. And so what we're trying to do is communicate with them because this was an addition onto the main hospital. It essentially is freestanding, but we're just communicating with them the best level of care for that facility. And then we have talked to Carteret County about expanding the facility grounds itself to add on for a lower level of care. So we may be able to provide a higher level of care on the hospital side, and then on the grounds, build and add on to for a lower level of care. Because there is no county DSS that I don't work with today that doesn't have a kid sleeping on a couch with a social worker who's there all night long. I don't know how she can function the next day. But I'll call looking for placement, and they'll say, call me back when you find it. And so just like with our IVC program where you're trying to there's not this really challenge around coordination of placing people in IVC, there's a huge challenge around placement. And some children are going to be harder to place because they're not getting the interventions they need. And I asked the young lady that was presenting this day, but obviously we went on a little bit. I hope Jeff is still here. That we can offer some of those interventions that maybe they'll be easier to place. you know? And then you can break that cycle, that generational cycle, because the more trauma you have as a child, the more substance use as a child, the greater the risk of a severe substance use disorder and mental illness later in life. So the next generation will still be at the same meetings. So that's really where we are.
Can you tell us your timeline for the sea level facility?
90 days.
Okay,
July.
so you're going to open in July. You can't offer all these services your day one, right?
No, we
Do
are.
you have some kind of general timeline, like start with detox and then move to?
So our general timeline, of course, not set in stone, the state controls all of that, is facility-based crisis and residential, and we're working on the best application for adolescent. And we suspect those will come online in 90 days.
Really?
The services that I'm currently providing, they're there right now, refurbishing the entire building. They've been there, you know, the whole time working on that. And so, but the other timeline is what we are immediately providing are some of those services in Carteret County that are available in Craven County around medication-assisted treatment, intensive outpatient services, basic counseling services, resource navigation, transportation, some of those other ones, and housing. We will be providing some of those immediately. Those are immediately available.
Transportation.
Transportation for recovery focus, not like to go to your mom's house, but like
Right.
you want to go to probation, you want to go to something that's needed. We'll be able to,
A doctor's appointment.
yeah, something.
Sign up for college.
And during that opportunity, you have to agree to be in services to work with somebody who's also in recovery that can work with you. So that's an opportunity. It's not a taxi ride. It's an opportunity to say, like, you know, when you're out there actively using and you stop taking care of your diabetes, this is why we're in the space we're in now. So we're going to try to put this together. And what have you been doing otherwise in your life? That's a counseling session practically. And that opportunity.
Like putting teenagers in cars.
I think it's so important, listening to you, that you are sharing what's happening to the mind, and the person who is addicted and the family and people working with them have to understand that. I have not clearly understood it until I listened to you today. It's actually what happens to the person and why they respond the way they do. So
I appreciate
I'm really excited about this.
When their brain is just all muddled, if you can just hold them and work with them as they clear that up, and then they get to a point where they look back and say, I would never go back. I'll do everything in my power.
I think it's
sure I
important
never
for the
go.
people around them to know that as well, to understand.
It's a complex disease because it's between the ears. If I break my arm, everybody gets it. But if it's between the ears, they don't always get it. Thank you.
All right, any more questions from the board? All right, if not, I'm going to turn it back over to County Manager.
Wow, thank you, Dr. Richardson. That was in-depth. Commissioners, at your last meeting, we talked about, during my manager's comment, I referenced that, you know, we're at a crossroads with where we are. And as you're aware, Carteret County has noted that they're leaving the Dick Center, which started in 2017. There were 3 anchor members, Onslow County, Carteret County, and Craven County. At your place, you have the most recent Dick Center report. It looks like this. And there's 2 parts I want to cover with you. So then I've got some folks, David and Jeff and Amber, here with me today. And I think there's some general conversation that needs to be had about what we're going to do and what we're doing. If you look at page 2 of the report, and this is for the month of March, at the top should say 3/1/24 to 3/31/24. On the right side, there is the percentage of use for individuals who entered the Dick Center. And last month in March, 9 individuals from Craven County, or roughly 8% of the bed space, were from here. As we've talked over the years, and Commissioner Smith, you're a member on the board now, Commissioner Mark had been on that board, Commissioner Liner, and Commissioner Dacey, going all the way back, commissioners that have served. We started in the 12 to 16%, 17, 18, and after Florence, there were significant challenges, not only in Onslow, but in Carteret and in Craven. We saw our piece drop down more to the 7 to 10% range. There was also a closure of a facility in New Hanover County around the 2018-2019 time period that caused an influx of folks from New Hanover County. Sometimes they were as much as 25 to 30% of the frequency of individuals in that facility. And I'm going to have you now, if you'll switch to page number 7. Page 7 is from 7/1/2023 to 6/30/2024, meaning it's a cumulative number. It's not ended yet, but we're in that period. And if you look at Craven there, 94 individuals throughout this year, calendar or fiscal year, roughly 8.9%. So you can see that 8% is holding pretty regular. The highest I've seen in this rating period was about 12%. I believe it was December. If you look at Carteret, they're roughly 9.5% for the year. And then you go over to Onslow, roughly around 50%. And it makes sense. The facility is in Jacksonville. It is in Onslow County. There is an ease of use component. They understand that. But if you look just above it at New Hanover County, the second highest user of the facility is actually not a paying member. And there's been great debate over that over the years. And there's been conversations with New Hanover County. And there were many years when we didn't have the Dick Center and New Hanover had the facility that folks from Craven, Onslow, and Carteret went there. And they didn't ask us for money. So we were in a bit of a pickle with that one. And it is what it is now. To Dr. Richardson's point, if you go back, I believe 2 pages. Yes, 2 pages. Go to page 5. You reference the different types of substances. While there's so much attention that's been put on opioids and fentanyl and heroin, and there absolutely should be, don't get me wrong, 44% of the folks are entering this facility because of alcohol. So there are other issues there. And most of the time, it could be a combination of a variety of these different substances that forces someone to get into crisis. However, there has been one that has, and Dr. Richardson and I spoke about this briefly last week, is stimulants, and that's meth. That's meth. And that's a resurgent problem here. He mentioned xylazine. That's a whole other component. It's being mixed in with different drugs, and it has a whole another series of detriments with that. I wanted to go over this report with you. I wanted you to have kind of a baseline for where we're at. As we're preparing the budget, there are some decisions that has to be made. I mean,
Yeah, could I say something about this?
Sure, please.
Originally, this was set up for 7 days in the Dick Center.
Correct.
And because we couldn't hold people there, it went down to 3 days and was doing exactly what the doctor was just talking about not doing.
There is, on average now, and I can find it in the report, and I don't want to speak wrong. Last time I saw, there it is. It's averaging stay is 3.47 days. So there is some repetitive nature to multiple volumes of detox. And, we've been involved with individuals over the years getting them there, and we've certainly seen folks having to go more than once. But there's no one way to solve this problem. Sometimes you need more than one time. I guess where the rubber meets the road for us today is inside our budget, there's $300,000 that is appropriated to the Dick Center. That started in 2017. It's been appropriated that way each year. There appears to be now an option. And I've spoken with the county manager in Carteret County, and I've spoken with their health director, Consolidated Human Services Director, Dr. Williams, that there is the ability for that same amount of money to partner and use the hospital that Dr. Richardson said. And as he noted, facility-based crisis, same concept. There's more in-depth details we heard when we visited the site about getting more to Commissioner Mark, what you said. And then I think Commissioner Hunt nailed it, is that when you finish the Dick Center now, you've got to go somewhere. It's not that facility. You have to leave. And oftentimes when there's not a warm handoff, you're going right back to the environment that you left without any, real cure. And I know that's a tough word to use here, but any real substantive improvement. And then those wraparound community service have to come in and play. And oftentimes, Commissioner Martin, that doesn't work because you're right back where you started. So getting them into a longer-term recovery model to support that through recovery housing and all the other different, ideas of how we deal with it. And I love the way you said between the ears problem, right? We got to get in there, and there's multiple ways you can attach that. So here's where we are. We got to put something in the budget. And we need to let Onslow County know something. They have asked, as recently as Friday, of our intention. They've got to make a plan. Based on what I heard on Friday, they are applying to the state for some financial assistance to continue the model that they have now. Our funds would obviously help keep the doors open, but it's not a guarantee. because even if they get our money and they match their money, there's not enough there to make it work. So they have to have the state funding to continue. There's no other way around it, or some other type of funding to make it work. I told the person I spoke with, I was very honest with them that this isn't a new issue for Craven County. For several years, and we've been clear, including Commissioner Smith and myself at a recent meeting, that we're not seeing what we need to see on this sheet to justify the expenditure of this type of money. 8% of the bed space, we're paying roughly 25% of the funding to run the facility. So there's something that doesn't feel right about that. I guess my question to the board is, how would you like us to proceed? You've heard additional information today. You don't have to make a decision today. We can come back and talk about it at your next meeting. But again, some communication to Onslow County needs to happen soon.
All right, Commissioner Howard has a question.
Yes, sir.
Not questions to comment. I questioned the $300,000 last year during the budget process and twice since then. So I'm more than 100% open to moving the funds to Dr. Richardson's program. It's closer, it's more in depth, makes a lot of sense to me for the citizens of Craven County. I wouldn't be, if we did move anything the direction of the Dix Center, not anything more than 8% would seem like a waste for me. So I don't even want to really do that. So that's just my opinion.
I would concur.
I think we should mention something here, Jack, is we put in 300,000, but part of that 100,000 was from the hospital.
Thank you,
Which
Commissioner.
the hospital does not want to do any longer.
Yes, sir. That's it.
Because they feel that it wasn't worth their while. However, the way the Dix Center worked was, if you were at the hospital before 12 o'clock at night, they would come and pick you up and take you down to the Dix Center. If it was after 12 o'clock, they would come the next day. So the hospital was getting an expense because they had to keep that person an extra day, which I can't get them to understand.
Commissioner Mark brings a great point. If you refer to page 2 of your report, this is the month of March again. It says diverted to Dix Crisis Center. If you look at the middle column there, Craven, 4 from the emergency room, 1 from jail. So that gives you kind of a pinpoint of how those folks are getting there.
So, several things, if I could, if you don't mind, Commissioner, just if I may jump in, and then we'll definitely go back to your comments. In the room today is some very key players in all of this, and I think it's worth noting, which definitely Jeff Merritt. We got Tyler Harris with us. Tyler's been a true advocate from our start years ago, been very involved. Major McFadden, he's helped us with the Hope Center. He's been a key player in this, and definitely Amber. I mean, you know, Amber, she's a lot of our brains behind what we've done, and thank you. So, and definitely Jack and all of his key staff. So I want to say thank you to all of you for what you've done and what you're continuing to do. And you're part of our team and got to be a part of this decision making as we go forward, you know, and how we move forward. So I want to get that off the table and make sure you understand we do appreciate you. Secondly, Commissioner Mark has been our advocate and on this issue with the hospital for years now. Actually, he was chairman when we started the opioid epidemic response team. We appreciate his leadership and what he has continued to do on that. It's been something at his heart. And I think he had some of the initial conversations with the hospital years ago in trying to get them on board. My question to you, Jack, and your team, has the hospital been introduced to Dr. Richardson's program? Did they know about it? They do.
Through Dr. Williams?
Yeah, yes, please, if you got,
Please, yes, sir.
please tell us what you know.
I mean, the Carteret Health.
Okay, I'm talking about Carolina East here in Craven.
No, sir.
Okay.
So, Mr. Chairman, if I could address that, I felt like you needed to hear from Dr. Richardson first before we did any wide-ranging community engagement. But when he and I met last week, we focused a lot on the hospital, what you just said, to the work Commissioner Mark's done, and how that cohesive environment works.
One of the key points, I don't want to interject too much, because I know this is nothing to do with me right now, but one of the key points was some of the interventions that we could do with the hospital of that last little slide that included Craven County, is that warm handoff you're talking about, there are some real good strategies to make that happen, whether it's peer support, resource navigation, peer support to connect with the ED so they're not waiting all night long. There's a lot of those things as well. And we have really good relationships with hospitals where in the ED, because that's where they're going to be really attending to make sure that they can have a warm handoff into the program. So, and Amber and your county manager, we have spoken about maybe moving forward to create some programs around your current team and supporting your current team in that process. But they have to have the right treatment provider to make that happen. They have to have the right housing provider and the right connections to resources. So, but we spoke about the Carolina Home, but we have not had that meeting yet. I think they were going to wait till after today.
Yeah, Jack, a doctor mentioned something very important there, that he and Dr. Williams was involved. Now, Dr. Williams comes to our board meetings. So it would seem to me, if you had a talk with Dr. Williams about this particular
We'll get
thing.
the right, same Dr. Williams?
Yes, yes.
He brought me here.
Dr. Williams is the health director in Carteret County.
That's correct, and he attends our board meetings.
You talking about the heart doctor, Dr. Williams, aren't you?
Yeah, the heart.
That's not the
doctor.
same guy.
Not the same.
Two different Dr. Williams.
Different Williams.
We got
I'm
two
sorry, I'm sorry.
No, it's easily to get it mixed up.
Yeah, but it'd be easy for him to talk to.
Yeah,
him.
so I don't want us to get off track here, but what I'm trying to say, what I'd like to say is, and I'd like for, definitely not trying to overstep my bounds with this board, but I think it's essential that the connection be made with Carolina East now. I mean, we've received this presentation. We need them as a partner with us going forward in this. I mean, it needs to be a collaboration. Regardless of whether they put in money, don't put in money, it has to be a collaboration. So I think, and y'all, if you disagree with me, board, you speak up. But I think that needs to be a next step, and definitely of and how we move forward is the connection with Carolina East and Dr. Richardson and his team and what he's doing. All right. So thirdly, we've heard from Commissioner Howard and his opinion. I would like to continue to go down the line and just kind of get a sense of how everybody feels. We don't have to do anything today, but we do need to give staff direction in how they need to proceed. We can do something, but Commissioner Mitchell, will go to you next.
I was concerned that the DICS program was both not going to benefit Craven County and that it was not going to provide what addicts and alcoholics need. I have not changed my opinion since I've been involved with this issue, and I would echo what Commissioner Howard said. I like Sea Level's therapeutic model much better. I think it has a much better chance of success, and I think our citizens deserve it.
Vice Chair Booker.
Yeah, I visited Sea Level, and my initial thought was, this is in the middle of nowhere, and how are you going to get staff to drive or move to Sea Level? Are you going to be at Sea Level?
I am at Sea Level.
You are, but I mean, you're going to be there. That's going to be your.
Yes.
Okay. Do you live there?
Well, I'm probably in Beaufort. I'm living there now.
Okay, great.
The staffing model that we use is specific to the remoteness of that area, but it also helps with the community. So we have really specific models around staffing for the needs there, and I think that I think that's not a problem for us. And
Okay, good.
Not with the wealth of applications that I've got for job interviews that we've
That's good news. That's good news. Because that was a concern as we drove there. Seems like it took us forever, but from here to there, it was a pretty good drive. But as the sheriff has pointed out, he's currently driving people all the way across the state. So it's going to be a big improvement for him as well as the rest of our county. So I think from what I saw when I was there, they have to do the remodeling and whatnot. But it's a great facility, and the fact that they take care of children, they got various pieces to this puzzle on board that Dix doesn't even begin to have. Mm-hmm. So I'm in favor of it.
Okay. Commissioner Moore?
Well, being Craven County has a big problem as far as the opioids and alcohol. I'm 100% behind the Dr. Thomas's program, based on my time spending with Dix Center. because as Commissioner Mitchell mentioned, it didn't include alcohol to the degree that she was talking about. And I'd be 100% as far as joining this.
Okay, thank you. Commissioner Hunt.
I'm an advocate to move forward. Having done a deep dive into recovery over the last year and a half or so, the facility is offering what Craven County wants and needs. And they're actually offering something that Craven County doesn't have, and that's mental health for our children. That's something we don't have. Jeff doesn't have that, that phone that he can pick up and make that connection. So I'm a proponent to move forward.
Okay, Commissioner Smith.
I thought I heard Ms. Cook say that she was complimenting Dix. Before I heard that, I was completely baffled that we were not getting the services that we should get, and I don't see anything on this report that indicates that. I'm excited about this program. It sounds like just what we need, but before we make that final decision, I think we need to find out just what services we are receiving currently with the children's program, if we're receiving them.
So can I stop you right there? You heard the presentation this morning. You heard what we heard and saw what we saw. And this is putting you on the spot, I know, but can you come and address that? I mean, can you offer to our substance-affected infants, and can you offer that same service?
So, and I'm not sure, and I would like her to expand on that, just so that I'm not misspeaking. But with the Governor's Stop Act, when you deliver a child and you do placental blood testing and you determine that there's substances there, there's an immediate referral into services. We do those immediate referrals into services. I don't know that your DICS program is an outpatient center, but a detox center. But the detox is getting referrals from parents that need that referral, and that's the assumption that I have there. But a referral to a detox is a great first step when applicable.
Right.
But as you mentioned, it's not enough. And not every provider does it. And I will tell you, I will work with many of the detoxes to pick them up and bring them into our programs, whether it's DICS or whether it's another detox around the, we're not here to usurp or supplant what's working. We're here to partner and strategically provide services. But for our program, we'll be able to take those referrals, and those women will be able to give them the right inpatient interventions and the right outpatient interventions. And then for those children that need services, we'll be able to provide those as well. So in all fairness, it's probably comparing apples and oranges, because that's not the program that we have. We have a very robust program, and it's all guided by evidence-based models of care. And so we just have a very different program. Does that speak?
Yeah, thank you, and I'm sorry I put you on the spot.
You didn't. No. And I can expand further. I don't want to take up too much time.
But I think Commissioner Smith brought a great point that needs to be addressed. So, County Manager.
So I spoke with Mr. Merritt to make sure I was thinking the right way. What I believe they were saying was they want the Board of Commissioners to continue to invest in resources for the parents. So children is a whole nother, when they're substance abuse connected, that has to happen in a medical setting. This is more to continue to invest in detox and long-term recovery. So whether it's Dick Center or at BC level, I think it's, I don't think they're worried about location. They want to worry that you have it.
Okay. I know they were expressing satisfaction with the programs that they were, services that they were receiving.
It's a good point.
And
So just for clarification, Dix is not offering services to these children.
No.
They're
No,
just
only
to the
adults.
parents. So so you're going to do.
We do all of that.
You would do the same thing.
Yeah, we do all of that.
I understood what she said was that Dix, thank you for supporting Dix, because that was going to help the parent.
Yes.
It had nothing to do with the children.
That's right.
The parent of the children.
And it very often is an important component of starting, if it's a certain type of substance or with a level, so.
Dr. Richards, before you sit down, you also will provide, we were told when we visited by Dr. Williams, the detox, that you will have a portion of your facility for detox.
So facility-based crisis does cover detox, as part of the competitive work that it does. And then we'll have a separate wing as well that will be detox. But just so you understand the strategic plan of aligning the staff, because we want to onboard slowly and appropriately and making sure that the quality of care is delivered. Facility-based crisis in North Carolina does also provide the detox services. So under that license, you provide the facility-based crisis stuff, the crisis management, as well as the detox services under that same one, where the detox only provides the detox.
Yes.
But to your point, we will have a wing that's facility-based crisis. We will have a wing that is just detox only. Yep. And then we'll have residential treatment, and then we'll have adolescent services as well. So that hospital, I don't think that they would have considered a lease if it were anywhere else. You know, it's a 40-year lease that Dr. Randall Williams in Carteret gave us, and it's ideal. It's an ideal because the community wants it. Yep. You know, not every community wants a behavioral health hospital. The county needs it, and this is a great opportunity for a facility that needs to be used. And they're doing something good. They're not building condos. They're meeting the community needs where they are. And we have sat down in extensive meetings over the last year and a half about what levels of care, what target populations, how are we going to do it. And we don't intend on just importing a lot of nurses from outside. We are intending on a lot of direct care staff that will be internally trained around med techs, direct care staff, peer support specialists, counselors, and others. So, but we have a very robust program that planned there. And so far, our track record has been very good, and I think it will be supported by some of the federal dollars I would like the county manager to kind of look for with us.
Okay. All right, thank you. I think it's only fair that we need to do it. We owe it to the citizens and owe it to these individuals. I mentioned we got Amber and Tyler and former DA David McFadden and Jeff here. Do y'all have anything that y'all, I mean, I'm not trying to put you on the spot, but I mean, anything that you think you could offer to us as a Board of Commissioners in making this decision, anything you want to add? You're welcome.
I would just like to talk a little bit about the detox services. We talk about detox, but really there's a difference where some of the programs are medical detox and some are non-medical. Dr. Richardson, do you want to talk a little bit about the type of detox services that you provide? Currently what we have right now is a non-medical detox through our contract with the Healing Place in New Hanover County. The Dix Crisis Center, they provide a medical detox. So when we talk about those services, it's important to note that there is a difference and there is a good reason to have a variety of those services available.
Yeah. I can speak a little bit about that. You have outpatient detox, which can often be done with opiate use disorder around home induction of Suboxone. But you know, there are a lot of situations where you may have a woman that's pregnant, and we often will get that. It might be even later stage pregnancy, where you really need to have somebody, even if it is opiates around pregnancy, you would still want what we call a 3.7 non-hospital medical detox. And then around certain substances like benzodiazepines and alcohol, it's life-threatening to have that as well. The non-medical detox, we also offer in our recovery housing piece. So you have a variety of those, and we provide all of those services. And we want to judiciously use the funds that are available. And if you only provide, in all fairness to everybody, if you just have a hammer, everything looks like a nail concept, if you're not providing a real robust program, you're not going to be able to really do an effective clinical assessment and place them in the effective level of care. And a lot of people need a lower level of care. They may not need a medical detox. And so we're not ever guided by the program as much as we're guided by the assessment to place in the services we provide. So I hope that answers your question.
Okay, thank you. Tyler, you got anything?
Just to say, I'm delighted to hear of this comprehensive program that's going on with the contiguous county. So I certainly share in some of what I've heard from each commissioner today to move in that direction. It's really a very positive thing. What we'll have to do, though, is to make sure our citizens know about it. Otherwise, it's not so much of a help. So we have to remember that. Or otherwise, that 8% usage is going to not be possible.
Thank you, sir. David?
Even if we were maximizing our use of DITS, I would still recommend that we transfer to this program for this reason. DITS is a single service, freestanding facility with a very limited purpose. We have the opportunity to partner organization that not only provides that service, but provides all the other service, the 12-step program, the therapeutic program, that we know we need for our citizens. It complements a number of the other programs that we're now building and establishing. I spoke with Dr. Richardson earlier. He's been in discussion with Hope Recovery Clinic, a center that we use, and they will have a partnership. So it is a great opportunity for us to provide a level of service that we currently don't have and work towards that navigation of the resources to maximize the resources that we do have.
I guess I'll speak from the children's perspective and echo on that is, you know, it sounds like that their services are going to be providing those to children with very high level acuity needs, which tend to be the ones that languish and you see kind of go through this cycle where they're at very high levels of either hospitalization or what's called a psychiatric residential treatment facility. They may go a little bit and then they're right back in the hospital to where we can try to get stabilization. We talk about all the time with our children that what we see those who we have trouble stabilizing and trying to achieve permanency are those level of children. You know, I'm talking about long-term. Short-term, as Commissioner Hunt said, we don't have a resource like that that's here to where we can hopefully get stabilization. And then I don't know what the time frame would be in regards to that hospitalization to where we could get stabilization and try to find a appropriate level of service that will start working with these children and continuing them on their journey to try to reach a stabilization level to where they would not need such high level services. Yes, they'll probably need supports for the rest of their life. However, you're not going to have to be in a locked facility or some hospitalization. You know, you can maybe just have, you know, individual counseling, or you can have some other medication treatment to where they can essentially function in school. Then they could, you know, build upon that school and go and have a well-paying job and, you know, have a family. So that is something that we do not see. I mean, some of the things that frustrates our, you know, the staff in child welfare, not just in Craven County, across the state, that causes burnout is that it's just like you're cycling. And that you're seeing that, you know, this child, and you're knowing that, you know, they're getting ready to go to this level of placement, and that level of placement is getting ready, you know, is getting ready to, you know, discharge them because of the most minor thing. And that's something that I was talking to Dr. Richardson about, is that we've really got to get it to where we get a good stabilization of a child to where you can, what's called in the industry, is level them down to where they're in a family setting, and that's where they can function. You know, you may have, you know, some little bit of regression, but it's where you can easily address that and get them back in that family setting. I mean, because it's almost like we're institutionalizing children now into that point where it's, I mean, just a pathway, you know, from, you know, hospitals, psychiatric residential treatment facility, and when they get to be adults, all those services drop off, and what's other institutions that we know that. So I would just really, that's something that is sorely needed, you know, not only for our children in Craven County for region, but for North Carolina. You know, I do say that the model in substance abuse, as Commissioner Mitchell said, the therapeutic model is one that where you have those different stages. I mean, it's one thing to just get the substances out of your system. However, that doesn't go with your cognitive processing and thinking. You know, what happens to where, you know, after those 3 or 4 days, and then you're right back and you're out there on your own. You know, sometimes you go back to what you're comfortable with if you don't have those supports around you. And I think that would also help us as we talk about in our, what we see in child welfare. Substance abuse is by far number one. I mean, 66% of our children with substance abuse was either the sole or some type of contributing factor when it comes to children coming into foster care. I don't have those numbers for assessments, but I would say it's probably close to that. So you heard our presentation today, the substance abuse affected infants, they're going up. And we're talking about where you can try to meet people to where you can really make that difference. And you know, you've got to reach them when they're in crisis. If you're sitting in a hospital and you're having someone that goes in and tells them, you know, your baby is having withdrawals from fentanyl or opioids or, you know, amphetamines, and you're talking with them and you're saying, hey, look, well, here's your crossroads. You know, we're going to have to make sure the child's safe, but you're going to have a pathway to still stay involved in your children's life, with being able to offer them something, you know, right then and there. We talk about it, I've seen it in child fatality cases where, you know, things have happened to where a parent has come into the emergency room and says, hey, it may be 12:30 at night, and they say, I'm ready to go into treatment. And they say, well, we don't have anywhere for you. Gone. You don't know if that's coming the next day or if it's coming 3 years later. So I think it's good to have these resources here. I like the long-term, the long-term recovery model that this is, rather than just going to detox. It's a great, you got to start there, but how do you move forward from that?
Okay. Thank you, buddy. Appreciate all the comments. Jack?
Mr. Chairman, I think I've heard a lot of things. I just wanted for the record just to tell you what you're doing now. This was part of sort of the whole picture. So you have the Dix Center, which we're paying for in Onslow County. It's county funds, Carolina East funds, and then our mental health maintenance effort funds that go toward that. We have Hope Recovery Homes, which David mentioned. 3 ways that's funded: through a COSAP grant David and the Sheriff's Office got, opioid settlement funds, and county funds. Just in the last 2 months, we've got a contract with Healing Transitions in New Hanover County using opioid settlement money. We fund RU252. Heard a great presentation from those folks last week. They have a recovery home here. That's through county funding. And then we were funding a group called RLM with opioid settlement money, but they have ceased operations as of about a month ago. So that's kind of the matrix of all the things that we do. Each of them have a little bit different twist in how they do it. Mr. Merritt's working hard through the state right now for some grant funding related to the START program he's mentioned to you, which is a social work-based, child protective service-based program. Jeff, I don't know if you want to update the board on that while you're here.
If you'd like to just here. We're actually one of the 5 counties that has been awarded those funds, and we have a meeting on May 7th. We're going to find out more about those counties. So hopefully we would like to come back, and just so when we have questions there to be able to come and inform you more about what that program is. We talked about it a little bit, but a more formal presentation. Really it's just something that I think you're doing now. You're looking and seeing what it is that you need from a long-term aspect and try to change the way you've been doing business to address a very complex issue. Our model has been a social worker goes out there and makes a referral. This model partners us with someone who, has that lived experience with substance abuse and with family issues related to that, whether, involving their children. Also puts those services in very quickly rather than having to wait weeks afterwards. So, we'd like to come back and talk with you about that too, and the funding that would come along, from the state as well. We think it's been used in, Buncombe County for some time, but it's been used in other states as well. It is on an evidence-based list out of California to get fully, recognized as an evidence-based practice. We think that it will be there. The state is looking at rolling it out to the entire state. So, I'm a little bit eerie when it comes to pilots because I always think of NC Fast and things such as that. But when we look at what is happening with our families and here in Craven County, and going back to what Dr. Richardson says, we've got to do something to try to break the cycle. We'll be able to do it completely, no, but if you continue to stay where you're at, it gets further and further away in the distance. And I think that is something that we could hopefully try to do with this program as well.
Okay. Thank you, Jeff. All right. Commissioners, in what I've heard today, and if you don't want to take action, was fine, but what I heard today, I think about everybody's pretty much feels comfortable with the presentations that we've heard, the information we've received. So if you want, let's take action today to give staff direction. Commissioner Mitchell?
Yes, Mr. Chair, I'd like to make a motion that we cease funding the Dix Crisis Center and transfer that funding to sea level.
Okay.
Second.
We have a motion and a second. It is to cease our contribution to the Dix Center, and the monies will be
In
put
order
forward.
as of June 30th, 2024.
As amended.
Okay. All right. You heard the motion, second discussion. Commissioner Smith? Yes.
Now, do we need to have a conversation with the hospital folk before we?
Well, we have continued services without the hospital contributing.
Oh, so we're good.
And so I don't think we've got to have a facility. And I respect what you said, Commissioner Mitchell, Commissioner Smith, excuse me. I do think we need to have that conversation, but whether they contribute or not, we've got to do this.
So the last payment received was last fiscal year. They were budgeted in this year. We have not received that payment. It usually takes Commissioner Mark going over and discussing that with the team at the hospital. But they did fund last year, so all we don't have is the one for this year.
Yeah, I would say at this point, we're willing to go to 300. Let's make that the extra 100 if I can get it.
Yes, sir, I'd agree with that.
Good point, though. And we will definitely, there's going to be a lot of conversations with them in the next few days and weeks. All right, we have a motion. We have a second. Any further discussion on the motion? If not, Madam Clerk, if you will, call the roll.
Commissioner Howard?
Yes.
Commissioner Hunt?
Yes.
Commissioner Mark?
Yes.
Commissioner Mitchell?
Yes.
Commissioner Smith?
Yes.
Vice Chairman Booker? Chairman Jones?
Yes. All right, motion passed.
Mr. Chairman, I will generate a letter for Onslow County to let them know of this action, and we will begin working with Carteret County, and I'll say it wrong, ICGH, I believe, moving forward. I know I'm going to get it wrong, but that's where we go.
Dr. Richardson, we thank you for being here today, for your presentation, and we do look forward to this, to working with you. You see our team. These are the key players, and so any way we can help you, we're here to work. Okay, thank you, sir.
Mr. Chair, I apologize.
Yes, ma'am, understand. Yeah, we definitely excuse you. Yes, ma'am. All right, Commissioners, item 7 is appointments. You have pending, current, and upcoming. Does any commissioners have any pending appointments? All right, here none. We will go now to current. You have, the first one is the Craven Aging Planning Board. You have the nomination, well, you have the applicant of Rob Payne, who seeks reappointment. What's the desire of the board?
I would move to reappoint Rob Payne.
Okay, we have the nomination of Mr. Payne. Are there additional nominations? Here none, we will set by acclamation. All right, next is the Nursing Home Community Advisory Committee, and you have Annette, how you pronounce that last name? I'm sorry.
Laura Conte.
Okay. This lady has completed all the necessary training, and ECC is requesting her appointment. Commissioners, you know that is a new process.
She's actually been through the process.
Okay, she's been through the process. Okay, it's very complicated. It's not just that we can put somebody on there anymore. They have to go through this process, be trained, and qualify. So what's the desire? Okay, we have the nomination. Is there additional nominations? Here none, we will set by acclamation. All right, Commissioners, are there any that we've missed on the current? All right, here none. You see the upcoming terms expiring. Please take note of those. Anything else on the appointments today? All right, next we go to the County Attorney's Report. Mr. Harry Grady, item 8. Good morning, sir.
Mr. Chairman, Commissioners, good morning. I have 7 items for your consideration this morning. My apologies. All involve property the county has acquired through the tax foreclosure process, and all the properties we own jointly with the City of New Bern, and the city has already given its approval to each of the 7 action items, so I won't have to repeat that 7 times this morning. The first item is a final approval for 1904 Washington Street, parcel 8-070-012. The initial bid was $10,000. There were no upset bids, so the $10,000 becomes the final bid. The past due taxes and cost of foreclosure were originally $2,925.31, and the tax value of the property is $20,000. I would suggest the board consider giving approval to this.
What's the what does the board like to do on this one?
I would say let's pay it. Go along with the city.
Should you make a motion?
I did. I said, let's move.
We'll get a second?
I had
A second.
Okay.
I don't know.
Got a motion, a second. Do we need a roll call on this? No. All in favor?
Aye.
Okay.
Did you have a question for me?
I was curious what that property was behind that with the circle lap on it.
Washington, oh, excuse me.
No, go ahead. You may know better than probably.
Washington Street is near J.T. Barber. When you
So
go
that's
over-
that school property back there? Is that what that is?
No, the school doesn't own the property.
What's that?
Oh, right. I mean Washington Street, yeah.
It's neighbor to the, I guess, east.
I guess that's the football field and
Yeah.
the track for the school. Yep.
That's, okay.
Okay.
Street.
All right, great. The second item is property located at 1407 Garden Street with a parcel ID number of -013-064. The initial bid was $2,700. There were no upset bids, so $2,700 is the final bid. The original taxes and cost of foreclosure together were $6,124.07, and the tax value of the property is $5,400. I would suggest the board consider approving this one as well.
Okay, do I have a motion?
I move to adopt the resolution.
Second.
Second.
Got a motion and a second. All in favor?
Aye.
The third item is 1411 Garden Street with a parcel ID number of 8013063A is in Apple. The initial bid was $3,000. There were no upset bids, so the $3,000 is our final bid. The original past due taxes and cost of foreclosure were $3,239.14. And the tax value of the property is $6,000. I would suggest the board approve this one as well.
A motion to approve?
So moved.
Second.
Motion and a second. All in favor?
Aye.
Thank you. Item 4 is 1302 William Street with a parcel ID number of 8013065. The bid amount for this was $3,000. There were no upsets, so that is your final bid amount. The original cost of foreclosure and past due taxes were $3,332.73, and the tax value of the property is $6,000. I would request that the board approve this one as well.
So moved.
Second.
All in favor?
Aye.
Number 5 is 1013 Bloomfield Street with a parcel ID number of 8006208. The initial bid amount was $3,000. There were no upset bids, so $3,000 is your final bid. The original cost of foreclosure and the past due taxes were $15,032.34, and the tax value on the property is $6,000. I would request the board approve this one as well.
So moved.
I'll second it.
Okay, all in favor?
Aye.
Then we've got item number 6, 1017 Bloomfield Street, parcel ID number 8006206. The initial bid amount was $3,000. There were no upset bids, so your $3,000 is the final bid. The original past due taxes and cost of foreclosure were $10,485.53. The tax value of the property is $6,000, and I would request the board approve this one as well.
So moved.
Second.
Motion and a second. Approved. All in favor?
Aye.
The seventh and final matter is an initial offer to purchase involving a parcel on Lincoln Street with a parcel ID number of 8013016. The offer amount is $4,250. The original past due taxes and cost of foreclosure total $3,070.65. The tax value of the property is $8,500. I would request that the board approve this one also, and we'll get it out for upset bids and have it back before the board when that process is concluded.
Okay.
So moved.
Second.
Motion and a second. All in favor?
Aye.
That concludes my report, Mr. Vice Chairman and Commissioners, and
Can I ask
that's...
one question?
Yes, ma'am.
Why is, one of these properties, why does it cost so much to close on some of them, on 8?
Well,
15,000, some of them are like 2,000 or 3,000.
You've got a couple of different factors, and there is admittedly wide variation over the years. Your starting point would be, the past due taxes, certainly. If the parcel hasn't paid taxes for years or decades, that can be a high number.
Okay.
When you're in the city of New Bern, you also have abatement liens that get tacked on for, demolishing a home or cleaning up the property. The city can charge that as taxes, so that'll drive the number up. And then the third factor you typically see would be on the attorney's fees side. If the property is heir property or is a difficult title exam or there's some underlying real estate ownership problem, that can drive up the cost on the attorney's fees. And so,
All right, any other questions? No, thank you, sir.
yes, sir, thank you.
All right, county manager's report, Mr. Vite.
Mr. Chairman, Commissioners, thank you for the opportunity. I'll be brief today. Last week, I attended the Craswama meeting, our regional landfill. 2 points there, just wanted to mention. The landfill is continuing with their litter pickup, so twice a year they pay for any main thoroughfare with trash trucks, particularly ones that are hauling to the landfill where they drive. They are now paying for that. I think it's been a great program, because what they're doing is picking times when the state is not out there through the normal DOT pickup. So we're adding 2 additional. It's typically this time of year. Many of you may have seen going down Highway 70 and Highway 101 earlier this month, or earlier in March. Also, they submitted their annual budget to the board. There was a proposed tipping fee of $1 per ton. That does have impacts on our programs here. However, $1 a ton is on the lower end of how they could increase their fees. So think about their tipping fees like their tax rate at the county level. Okay, so it's how they generate money based on a per ton basis. So we've already worked with staff, Mr. Jean and Stephen, on what that will mean for the budget. Second, just as a reminder, at your next commissioner meeting, it is one of those meetings where there's a bit of pageantry. We'll have both the public schools and the community college presenting their annual budget request to you. So just as a reminder of that typically goes very beginning of our meeting, and we'll move through with those presentations. Then a month from now, you will receive your county budget. So that'll be when Craig and I turn that around, hand it out to you. It becomes your budget at that point. And then that week, we begin our budget work sessions. As we've noted at your last meeting and now in your memos, we've articulated those dates and times to you. If you have any questions about that, please reach out to one of us. And lastly, Commissioner Bucher and Commissioner Mitchell and I were able to attend a ribbon cutting for a new apartment complex last week out at Carolina Colors. I was amazed at what those individuals have done, what they've built. It is a very nice unit, and it is 70% occupied. And that's what I wanted to share with you, is that there are still strains on our housing market here and our environment that we need to be mindful of. 70%, and they, from what I saw, those 70% are getting a really great apartment, a great complex, but we need more of that as we move forward.
That's in less than a year.
Less than a year. Any questions for me?
Any questions from the board? No?
Thank you.
Sir. All right, Commissioner's report. Vice Chair Bucher, you want to start?
Yeah, just one quick comment, and that is I did a tour along with the couple other folks last week of the Highway 70 project in James City with the project manager, and we drove the whole project, and she explained to us everything that's happening. It is an unbelievably complex thing. So I like to invite her to come to one of our meetings and brief all of you on where that project stands and where it's headed. Just one quick thing, and that is the entire length of the access roads from Carolina Colors back to the river are going to have curbs, and that's a lot of work that isn't done yet. So, Mr. County Manager, if it's appropriate, I'll have her invite her to come to our next meeting.
So you want her to come to the first May meeting?
Yes. Okay. Thank you.
Okay, thank you, sir. Commissioner Howard.
I don't really have a report. I'll just, again, reiterate thanks, Dr. Richardson, for coming. I appreciated the Abraham Maslow quote, one I probably use weekly, and also tells me a little bit about your treatment approach and dealing with people. So thank you for that.
Thank you, sir. Commissioner Moore.
Yeah, I would like to thank Dr. Richardson also for his presentation. I thought it was excellent. In addition, I was at the hospital, held a recruitment in our convention center, and we were able to sign on 39 new nurses, which is definitely needed. So that was a good plus for the hospital. as well as getting a credit for $450 million in case we needed it due to some cyber attacks on our computer system as some of the other hospitals. I also attended a TDA meeting, which we had a presentation by a company on how to go about getting more people coming into our convention center. That's it.
Okay, thank you, sir. Commissioner Hunt.
Yes, I have a couple quick things. I attended the civilian military community meeting last week. So I want to let everyone know what's going on base. The base has secured the C-130 contract that they spoke about. So what that means is when the skipper was here talking about 900 military members coming versus 1,100 military, it's 1,100 that got that contract. So the C-130s are coming. They're about to begin their environmental and range study for their amphibious training. So I believe they're going to be reaching out to Craven County staff to help with that as well. Very similar to our land use study. The MQ-9s. Commissioner Booker, do you remember the MQ-9s? The drones. We have 2 of them on deck. If anyone attends the Air Station show that's coming up in May, they'll get to see them in action. They'll be flying. The other thing is that we have 1 complete F-35 squadron on deck. They've completed training in Europe. They're back home and ready to defend our nation and keep us safe. So those are the good things. Not all good things come out of that meeting, though. The skipper of the Naval Clinic on board the base said they are going to man their health care at 40% for their military members. So that's for their military members and their families. So those people will be seeking services outside the gate. Not that they offered a full range at the clinic, but they did offer services. They're only going to man them at 40%. So just another reason that it's critical that we get VA healthcare down here in Craven County, because if we can get any of our veterans seen at our VA healthcare providers, that takes them out of Carolina East, that takes our civilian counterparts out of CCHC, and relieves some of those stressors there. Mm-hmm. So that's what I've got from base. That's all.
Thank you, ma'am. Commissioner Smith.
Thank you. I have scheduled a town hall meeting on April 30th. It's going to be at the Senior Center, 811 George Street. And the main feature is going to be our own county manager, Mr. Jack Byte, along with others who work in the system. The health department will be featured, and social services, and they're all going to bring important information to the citizens. So we look forward to having that town hall and excited about the folk who are going to be on the roster. And I hope that our citizens will come and attend and learn, be informed about what's happening in the county, services that are available to them. That's it.
Thank you, ma'am. All right, commissioners, you have anything else to bring before the board before we go in closed session? All right, here nothing. In our agenda packets, item 11, the board is requested to go in closed session pursuant North Carolina General Statute 143-31811 A and 3 to consult with an attorney to protect the attorney-client privilege. Anything else to offer, Mr. County Attorney? Okay. Do I have a motion that we go into closed session? We have a motion and a second. Any discussion on the motion? Hear none. All those in favor signify by saying aye.